Hello, everyone. Can you guys hear me? Please write in the comment, the chat box. Great. Awesome. Awesome, guys. Awesome. So let's just get started. Yeah, great. Awesome. Okay, let's start. So today we are going to start hypo and hyperthyroid. Okay, now let's get started with hypothyroidism. Very easy, okay. As the name suggests, you have low thyroid. Let's talk about the diseases now. The first disease that you see in hypothyroidism is Hashimoto thyroiditis. As the name suggests, it's a sort of inflammation, right? Thyroiditis. So you're right. It is a chronic autoimmune thyroiditis. So chronically autoimmune disease causing inflammation. Most common cause of hypothyroid. The way the first stage right things is very well, actually very unique. So the first thing they write is always almost most important, and then goes into not least common, I should say, but most common cause of things are going to be up top, and then the line is just gonna go on and on. Okay, uh, so here's the most common cause of hypothyroidism, um, and in iodine sufficient regions. Okay, associated with, because it's autoimmune, so it is associated with HLA DR3, which differs by ethnicity, increase risk for primary thyroid lymphoma, high yield, that it would increase the risk of primary thyroid lymphoma, which is typically which one? Diffuse large B cell lymphoma. Again, diffuse large B cell lymphoma. Uh, okay. And what are the findings we will see in Hashimoto's? In Hashimoto's, we will see moderately enlarged, high yield, non tender thyroid. So, enlarged but non tender thyroid may be preceded by transient hyperthyroid state, which is called Hashitoxicosis, okay, which is basically saying, okay, toxicosis hyperthyroid. So, they named it Hashitoxicosis, calling Hashi means Hashimoto thyroiditis, and being an hyperthyroid state, which is only transient. Okay. And why do we have in hypothyroid? Why do we have hyper? Because of follicular ruptures. You have inflammation causing rupture of follicle that leads to release of thyroid hormone. And when the thyroid hormone goes in the bloodstream, you are going into thyrotoxicosis, but it's only transient. It's only transient hyperthyroid. Okay, that's one thing. Second thing is in serology. In serology, what do you see? You have a positive, high yield anti-thyroid peroxidase. So if you recall, there was only one enzyme, TPO, thyroid peroxidase, which was doing everything, right? So oxidation, organification, coupling, right? So now that enzyme, now there is an anti-thyroid peroxidase antibodies. So there is an enzyme, there is an antibody against this. So when you knock this out, you will not be able to make thyroid hormones, leading to hypothyroidism, right? Simple. And this anti-thyroid peroxidase is antimicrosomal and anti-thyroglobulin antibody. So two sort of antibody you have to think about, and anti-thyroid and anti-thyroglobulin antibodies. Okay. On histology, what do we see? High yield again, Hürthle cells. Hürthle cells, let's take a look at that. Picture A is the Hürthle cell. So here is we have the Hürthle cell. What are these Hürthle cells, by the way? So these are, again, follicular epithelial cells which went into a metabolic change. A metabolic change. And why did this change occur? Well, because of chronic inflammation, they couldn't stand that chronic inflammation. They wanted to change. Now they're called Hürthle cells, but they're not just normal follicular cells. Okay. And with the specifically, what do we see here? The Hürthle cell. These will have eosinophilic. Again, eosinophil means pink. Okay. So eosinophilic cell, right? Filled with granular cytoplasm. So if you look closely, you'll see granules within the cell. So eosinophil cell with, because the name, not a lot of time they have mentioned Hürthle cell as a name, because that would be just right away giveaway, right? So the histology is very important. Cells with eosinophilic cells with granular pattern or granular cytoplasm is this specifically for in case of in the history with everything presentation with the thyroid, hypothyroid. So you'll think about Hürthle cells. That's one thing. Second thing on histology, you will see lymphoid aggregates, high yield again. Here you have lymphoid. Why lymphoid again? Because you are looking at chronic autoimmune inflammation. That's why there are the lymphoid aggregates with germinal centers. And again, if you think about germinal centers, that's why you're making this this thyroid lymphoma, which is diffuse large B-cell lymphoma, because in germinal centers you get that extra layer which has the which has the propensity to go into diffuse large B-cell lymphoma. Okay. What else we can think of here? So one thing, not only you will have lymphoid aggregates, just add one more thing here. You will see lymphocytes plus you will also see plasma cells. So two sort of cells, inflammatory cells, you will see Hürthle cell, lymphoid aggregate, germinal centers, plasma cells. Okay, now let's talk about something postpartum thyroiditis. This postpartum thyroiditis, let's erase this part. It is mild. Okay, it is self-limiting variant of the main disease we're talking about, Hashimoto thyroiditis, which arises less than 1 year after delivery. So as the name suggests, postpartum, but time frame less than 1 year. So any female less than 1 year develops into hypothyroidism, but only self-limited, meaning it's going to go back to normal. You can think of postpartum thyroiditis. Okay, here again, you will have a natural history of hyperthyroidism first within the 3 months of birth. So this lady postpartumly will present with hyperthyroidism for the first 3 months, and then will go into hypothyroidism, and then eventually the lady is going to go into recovery or euthyroid, meaning the thyroid is going to be normal state. So hyper, then hypo, and then eventually normal state. And that is also very important. Okay, so yeah, I guess that's pretty much it for Hashimoto. So let's just review this quickly. In Hashimoto, very simple, as an autoimmune, got to know the antibodies. Okay, antibodies out of a high yield here. So what do we have? Antibody, we have anti-thyroid peroxidase antibody and anti-thyroglobulin antibody. So not only the enzyme itself, but also that thyroglobulin, two types of antibodies which are associated with Hashimoto's. Histologically, Hürthle cell, lymphoid, plasma cells with germinal centers. Those germinal centers can go and form diffuse large B-cell lymphoma. This is autoimmune disease, so it is associated with the HLA, DR3, but this is, again, differs by ethnicity. Okay, and this is seen where? In the iodine sufficient region. So not the developing world, the developed world, you will see iodine sufficient regions, right? Okay, and predominantly, again, high yield, you will have predominantly this patient is going to be in hypothyroid, but initial stages are transient hyperthyroid because of follicular rupture leading to release of that hormone. Okay, and that's going to give you so hyperthyroid first, and then it's going to go predominantly it's going to be hypothyroid. By the time we see in a question stem, it's going to be hypothyroid. But again, they might confuse you with hyperthyroid. But got to look at these antibodies, okay, and the histology. One of the variants is postpartum. Again, postpartum less than 1 year after delivery. Again, same natural history, which was hyperthyroid, then hypothyroid. But here's the difference is that there's a recovery because it's self-limited. It is self-limited, so there is a recovery. Okay, and what else we can think of? So if you were to look at the labs, which they did not mention, so labs are going to be, you will have low T4 because it's low, it's a hypothyroid, so low T4, and that's going to cause increase in TSH, right? Now T3, again, T3 is going to look normal. This is very essential. I did talk about this in physiology, so do take a look at T3. T3 is going to be normal. Why is it going to be normal? Because T3 fluctuates. The level of T3 fluctuates. So do not look at the level of T3 because if you remember, T4 converts into T3, right? So the level is always either up, either down, either not normal. So we cannot think about that. The way we look at hypothyroid or hypothyroid, the most important things are T4 and TSH. And T3 is just a metabolite of T4. So we don't, it fluctuates, the level fluctuates. And also it has a shorter half-life. One more thing, fluctuation and shorter half-life. That is why we don't look at T3. Okay, and that is going to be all for Hashimoto. Let's look at the next one. We have subacute granulomatous thyroiditis, again, inflammation. It's also called dequarine thyroiditis, usually self-limited. Natural history, again, you have a transient hyperthyroid, which and then causes euthyroid normal, and then hypo, and then it again goes into euthyroid. It is often preceded by a viral infection, high yield, that there is going to be viral infection, and then there is going to be something known as subacute granulomatous thyroiditis. Findings, high yield, again, because you have inflammation, all of that is inflammation, granulomatous inflammation, right? You have increase in ESR, jaw pain is there, and highest yield is very tender thyroid. Very tender thyroid is your dequarine thyroiditis. So the mnemonic here is dequarine is associated with pain. Pain is painful thyroid or tender thyroid. On histology, you will see granulomatous inflammation. Okay, so granuloma will be there. So the pathology, let's just take a look at one more time the pathology here. So we said it is preceded by viral infections, right? So after you have infection is after you have an infection, which is going to be your post-viral. So you will cause something called post-viral syndrome, okay, in which there is going to be destruction of thyroid follicles. When you destroy these thyroid follicles, again, they are going to release the preformed thyroid hormone, causing hyperthyroidism first. Okay, and then when this level goes down, then you are going into euthyroid, because levels are getting normal. But instead of staying here, because it's self-limited, instead of staying here, it goes into hypothyroid. That means that we are not making any thyroid hormone. That is why we are going into hypothyroidism. And from hypothyroid, eventually we will go back to the euthyroid state, which is total normal formation of thyroid hormones. Okay, the time frame is also very important here. So let's just talk about the time frame. So the time frame is that you have hypothyroidism, and this hypothyroidism, within less than 6 weeks, it has to go back to euthyroid state. It will go back, let's just say that. it will go back within 6 weeks because it's self-limited. Self-limit how much time frame 6 weeks. Okay, this inflammation is going to get you back on the normal state of thyroid within 6 weeks. Okay, that's important. Other than that, where is it? Okay, yeah, that's going to be all. So let's just review this part. Subacute granulomatous. With the granulomatous, you should know, okay, with the name, as the name suggests, okay, first of granulomatous, so you are going to see granulomatous inflammation. Let's take a look at picture C. In the picture C, we see granulomatous inflammation. Not in C, it is in C, granulomatous inflammation, okay. Oh yeah, here. The quality isn't that good, but so you can see within the follicles, you have granulomatous inflammation. Okay. Now, one more thing that you have to know with the granulomatous inflammation, which cells are involved. Well, the cells that are going to be there are going to be your macrophages and your giant cells. Okay, and that's basic simple thing, but you got to know this. Okay, so let's just talk about more. Just review this one. So we have self-limited disease, which goes from hyper to euthyroid, then hypo, then again euthyroid. Important. Okay, this is the cycle that it goes through. But more importantly, high yield, it's a very tender thyroid, very tender thyroid, because it's again inflammation and granulomatous inflammation. It is self-limited after post-viral infection. Okay, with that you will have ESR high. Okay, which is an acute phase reactant inflammation. You will see that. So this is not specific, but just there. What is specific is going to be jaw pain and tender thyroid, specifically here. Okay, granulomatous inflammation specifically here, with macrophages and giant cell specifically here. Okay, and that is all for subacute. Let's move on with Riedel thyroiditis. Riedel thyroiditis, it is called invasive fibrous thyroiditis, may occur as a part of IgG4 related disease spectrum. Example, autoimmune pancreatitis, retroperitoneal fibrosis, non-infectious orotitis. Okay, so these are all IgG4 related diseases. Hypothyroidism occurs in 1/3 of the patients. Fibrosis may extend to the local structures. Example, trachea, esophagus, mimicking anaplastic carcinoma. And this is high yield, that it mimics anaplastic carcinoma. Okay, because if you recall, you have a dense fibrous tissue, which if this here, let me put it this way, if you have, because this is a fibrosis, right? So this dense fibrous tissue extended beyond that, because it's going to extend beyond the thyroid capsule. So let's say this is thyroid capsule, it's going to extend beyond the thyroid capsule. And when you extend it beyond thyroid capsule, it looks like, because when we will see anaplastic carcinoma, that one does the same thing. It does not care, because it's a carcinoma, it does not care about a capsule. It just invades the capsule, right? So how do we differentiate now? Because they both are invading the capsule. Well, so differentiated. So the way we differentiate it, the first thing we do is, first of all, we want to see the age of the patient, and we will do the biopsy. So as a young patient less than 40, and second thing is going to be the biopsy. Biopsy will show thyroid cells and follicular follicles, right? So if they are in anaplastic, you will not see the normal cells or follicles, but here you will see normal cells and follicles. Okay, let's take a look at findings. Slowly enlarging, that also gives a clue. Okay, it could be anaplastic carcinoma. That is why you have to differentiate. Okay, again, hard, rock-like, fixed, non-tender. Only one thing that is going to be tender is going to be this subacute granulomatous thyroiditis. Other than that, I think most of them are non-tender, but let's read and we'll figure out more. But on top of my head, if you think about tender, you're going to think about decoy vein. Simple as that, okay? Um, Histology, you have thyroid replaced by fibrous tissue and inflammatory infiltrates. Let's look at picture D here. So you can see that the thyroid follicles, the whole thyroid is replaced by fibrosis, fibrous tissue, and a lot of inflammatory cells. Okay, and that is in the riddles or riddle thyroiditis. Okay, so let's talk about extra things here. So you will see hypothyroid in these patients, but on top of this, you will see something else as well. For example, these patients are going to, because this fibrosis is going out of this thyroid, it is invading this capsule and going, it invades the capsule and goes to the local structures and obstructs them, okay? So if it obstructs the trachea, if it obstructs the trachea, you're gonna, the patient is gonna present with dyspnea, and if it, which is shortness of breath, and esophagus, if it goes and obstructs the esophagus, which are very, if you think about thyroid, is you have thyroid, you have the trachea, right, and then you have the esophagus. So you could obstruct each one of those structures which are nearby, and obstructing will cause their symptoms. For example, with esophagus, is going to cause dysphagia, okay, difficulty swallowing. So you will see hypothyroid plus sign symptoms of this right here, and that's how you will think, okay, it's riddles thyroiditis, and on top of that, you have to think about, okay, it's the one which is going above and beyond the structure, which is invading. Where is it? Which is mimicking the anaplastic tissue because it is invading the fibrous capsule of the thyroid. Okay, because that's why it's called the invasive fibrous thyroiditis. So let's quickly go over with this. Riddle thyroiditis, it is invasive fibrous thyroiditis. It occurs as a part of IG4 related diseases. For example, they are the autoimmune pancreatitis, retroperitoneal fibrosis, non-infectious otitis. Hypothyroidism occurs in 1/3 of all these patients. Okay, fibrosis will extend to the local structure and also mimics the anaplastic carcinoma because it's going to extend beyond the thyroid capsule. That is why it's going to go, when it goes above and beyond the thyroid capsule, it's going to go into the local structures. Findings, again, slow enlarging, hard, fixed, non-tender thyroid. And if you look at histology, thyroid is replaced by what? Fibrous tissue. Okay, fibrous tissue and inflammatory infiltrates. And that is going to be all for riddle thyroiditis. Now let's take a look at congenital hypothyroidism, very high yield. Congenital hypothyroidism, formerly called cretinism, most commonly occurs by thyroid dysgenesis. What is the most common cause? Thyroid dysgenesis, which is abnormal thyroid gland development. Example, if there is an agenesis, the thyroid didn't even develop. Hypoplasia, thyroid developed, but it is very low. The organ size is not that normal. Hypoplasia of the thyroid gland. Ectopy, it formed in somewhere else. It did not form at the place it should have been there. For example, in the interior of the neck. Maybe it's ectopically present somewhere. Okay, all of these are your thyroid dysgenesis, that the thyroid has not been formed properly or in normal fashion, right? Or the second cause is going to be your dysharmonogenesis, saying abnormal thyroid hormone synthesis. You have the normal gland, but the hormone synthesis is not normal. Okay, example is mutation in the thyroid peroxidase. There's only one enzyme within there, so. And guess what? That enzyme is going to be involved. So mutation in TPO, thyroid peroxidase, in iodine sufficient regions. Now findings are very high yield, okay? With a child, with a congenitally, an infant, will have 6 Ps, pot-bellied, pale, puffy-faced child with protruding umbilicus and protruding tongue. Poor brain, high yield is poor brain development. If you take a look at child here, they have puffy face, protruding belly, and with protruding umbilicus and all of that, and tongue being enlarged as well. But with treatment, they probably look like a normal child. Okay, that is with the congenital hypothyroidism. One more thing, high yield, is going to be that initially with the congenital hypothyroidism, uh, these patients are going to be normal at birth. So normal at birth. And why is that? Because the mother, maternal T4 is giving all the thyroid, so they don't need it, because the mothers from the mother circulation, you're getting all the T4s. So initially, mothers, initially normal at birth, and these signs and symptoms will appear after the maternal T4 wanes, right? That is going to be there. So the treatment is going to be, again, the treatment is simple, levothyroxine, but you got to give earlier, okay, because they need it for brain development, right? So by 2 weeks, they need levothyroxine, okay? So newborn, then you ask, hey, if maternal T4 was covering, how do we know if the patient is a congenital hypothyroid cretinism or not? So the way we check it is called newborn screening. We do newborn screening on the patient, and that basically shows increase in TSH and decrease in free T4. We have a little bit from mother, which is eventually going to wane off. So by 2 weeks, start the patient on levothyroxine. Okay, that's with the congenital hypothyroidism. Okay, the next thing we have is going to be other causes. What are the other causes? Well, iodine deficiency, most common cause worldwide for sure. Iodine deficient states, right? Typically presents with goiter. So if the iodine is deficient, it's going to present with goiter, which is G. So let's take a look at G picture here. You can see goiter, enlargement of the thyroid gland. Okay, iodine excess will give you Wolff-Chaikoff effect, and that is also going to go into transient hypothyroid, right? Drugs, for example, amiodarone, lithium. Amiodarone causes, again, Wolff-Chaikoff effect because amiodarone contains iodine in it, and it goes into Wolff-Chaikoff effect. Lithium, non-thyroidal illness syndrome, also known as euthyroid 6 syndrome. Okay, euthyroid 6 syndrome, what you have here is you have low T3 with normal or low T4 in critically ill patients. Again, what is it? We will see hypothyroidism in critically ill patient because that's called euthyroid 6 syndrome. Okay, so in critically ill patient, just take a look at in the scenario of in the question stem, you have a critically ill patient and going into hypothyroidism. With the hypothyroidism, you look at T4, look at TSH. Now, the problem here is going to be that not only you have T4 low, which you will see in hypothyroid, right? But here you will also have TSH being low. So that is how you will say, okay, this patient did not go into post-viral or anything else, but this patient has a euthyroid 6 syndrome because you have, even as a negative feedback, this should have been up, right? So if you have a low T4, TSH should have been up, should have been high in hypothyroidism. But here it's different. What is different here, you have low T4 and a TSH is also low in critically ill patients. And that's how you diagnose euthyroid 6 syndrome. Okay, with that, yeah, that's pretty much all. Let's just quickly review the whole page and move on to the next one. Simple hot Hashimoto thyroiditis, it is an autoimmune thyroiditis, okay, which will cause everything is non-tender if you look at all of them, non-tender thyroids. But one thing which is going to be tender is the name suggests, which is you got to know the mnemonic, okay? Decurrent pain. Decurrent is associated with the pain, okay? Decurrent pain, okay? Which is going to be tender thyroid. With the Hashimoto, two antibodies, anti-thyroid peroxidase, anti-thyroglobulin antibodies, Hurther cells, lymphoid aggregates, germinal centers, and plasma cells. Okay, it can go is so one of the variants is postpartum thyroiditis, which is again is a variant of Hashimoto, which is self-limited. Here again, whenever you have a natural history, first of all, you will see hyperthyroidism. Why? Because there's a destruction of cells leading to release of pre-made hormone that causes hyperthyroid first, leading to hypothyroid, and then euthyroid. With the subacute granulomatous thyroiditis, all you have here is again self-limited disease, hyperthyroid here because you have, if you think about this versus the top one, in the top one is a postpartum woman, right? But with the subacute granulomatous thyroiditis, which is decoraine, is going to be after post-viral infection. It's going to cause hyperthyroid, then euthyroid, then hypo within 6 weeks, going back to euthyroid state. Okay, it because the name suggests granuloma, so granuloma is going to be there. Riddle is just fibrosis of the thyroid, and that would invade the local structures. Trachea, esophagus. It's a slowly enlarging, hard, fixed thyroid. Here, simple, it's going to be again fibrous tissue being replacing the normal thyroid gland. Congenital, everything you have low, but again, it's the 6Ps which are high yield. Pot belly, pot belly here. Let's just draw it here. You have a pot belly with protruding umbilicus, protruding tongue, or puffy face, and poor brain development. Other causes, iodine deficiency is going to present with goiter, iodine excess, which is Wolff-Chaikoff effect, drugs, high yield, imidrone, lithium, and non-thyroid illness syndrome is going to be your euthyroid sick syndrome. And that is going to be all for hypothyroidism. Okay, let's have a 3 minutes break. I'm going to put out the timer and we'll be back in 3 minutes. I'm put out timer. Okay, let's get started with the next thing here. Hyperthyroid. Let me zoom in. Okay, now let's talk about hyperthyroid. Hyperthyroid, and the first thing we have is the high yield disease called Graves' disease. Okay, in the Graves' disease is the most common cause of hyperthyroid. Okay, again, as I said before, the first thing is always going to be the most common. That's how the first is right things. Okay, uh, hyperthyroid. The second thing is going to be a thyroid stimulating immunoglobulin, which is your antibody. Uh, as the name suggests, if you think about it, thyroid stimulating immunoglobulin. So you have an immunoglobulin, which is IgG, which will stimulate the thyroid. Okay, can cause transient neonatal hyperthyroidism. High yield is a type 2 hypersensitivity reaction. It will stimulate the TSH receptors wherever you have the TSH receptors. So where you have TSH receptors, so you have the TSH receptor on thyroid, causing hyperthyroidism. Makes sense. Simple. Causing diffuse goiter. Makes sense. But now think about the other ways. You have TSH receptors on the dermal fibroblasts. Location pretibial. Pretibially, we have the TSH receptor is going to cause myxedema. So pretibial, in other words, shin edema, which if you press on it, you will be able to press, because we will see that part. But just remember where the TSH first is thyroid, second is dermal fibroblast on the pretibial state, third thing is orbital fibroblast. Orbitals, again, as the name suggests, orbitals, eyes, right? So Graves' orbitopathy. Okay, and then you could treat this by glucocorticoids, high yield. Graves' exophthalmos or Graves' orbitopathy can be treated by glucocorticoids. Now, there's an activation of T cells. Okay, activation of T cells causes lymphocytic infiltration of the retro-orbital space, right? And that is going to cause increase in cytokines, example TNF alpha, NIF gamma, and that is going to cause increase in fibroblast secretion of hydrophilic glycosaminoglycans, right? And that is going to causing increase in osmotic muscle swelling, muscle inflammation, and adipocytes count to increase. And that is eventually going to cause exophthalmos, which is picture A, exophthalmos. Often presents during stress or pregnancy. So whenever you have stress, for example, pregnancy or any other stress, it can present with exophthalmos, associated with, again, HLA-DR3, because it's an it's an autoimmune. So that is going to give you an HLA-DR3 and HLA-B8. Okay, let's talk about more important things here. Histology, high yield. You will see tall, crowded follicles. Okay, so here are the follicles. They are tall and they are crowded. Okay, and what else? Epithelial cells, crowded follicular epithelial cells, scalloped. High yield is a scalloped colloid. Let me zoom into the scalloping here. If you see the follicle, this is not up against the epithelium, right? It is. You can see the white surface. This is scalloping. So it is the scalloping, so it's called scalloped colloid. Colloid is not up against the epithelium, and that is called the scalloping or scalloped colloid. Okay, let's talk about some extra things. You got to know this is type 2 hypersensitivity reaction. First thing, it is an autoimmune disease, which is, so let's just write this down here. It is an autoimmune Graves' disease. It's an autoimmune disease which is triggered by antibodies, right? So triggered by Uh, let's just put the names here. So thyroid stimulating immunoglobulin, in other words, they can say TSI, again, thyroid stimulating immunoglobulin, or they might say uh, thyrotropin receptor antibody. So let's just write that one out. Thyroid receptor antibody. So TRAB is let me write, thyrotropin receptor antibody. And what is thyrotropin receptor? That's your TSH. Okay, so you have the antibody against your TSH. So antibodies that are stimulating the TSH receptor. Okay, and this is going to cause, simply as I just said, all of these, they're the same thing. They will stimulate your TSH receptor. And when you stimulate your TSH receptor, as you know that you have that TSH receptor on the thyroid itself, on top of that you have on the dermal fibroblasts and on the orbital fibroblast thyroid tissue, okay? And all of that will cause their own things, which are going to be on the orbital is going to cause exothelmos, on the dermal is going to cause peritoneal myxedema, and on the thyroid is going to cause hyperthyroidism, simple. Okay, that is very important. Second thing you can think of is, again, pathology of how things are really working out. So you have activation of the T cells. Okay, that activation of T cells would cause, would cause lymphocytic infiltration of the retroorbital space. So just remember, there's a lymphocytic infiltration, and that's going to increase cytokines. That is going to increase fibroblast secretion. When the fibroblast secretion of what? Of GAGs, which are glycosaminoglycans. When the GAGs are high, it's going to draw the water inside. So it's going to cause increase in osmotic muscle swelling. And because increase in cytokines, you are causing more and more inflammation, right? And you will have increase in adipocyte count. So all of that is going to give you myxedema. Okay, myxedema. In the myxedema in the peritibial in the shin, and myxedema in the orbital area, so leading to exothelmos. Okay, that is important. Other than that, not only you will see exothelmos, but these patients are going to present with diplopia. So with the exothelmos plus, you will see diplopia, double vision. So exothelmos, diplopia. Okay. With that, why do you have diplopia? Because you due to restriction of your extraocular movements. So extraocular muscles, they can't move here or there. It's going to give you diplopia. Okay. So this, again, it is treated by high yield is glucocorticoids. Where is it? Glucocorticoids. And if you know just here, why are we giving glucocorticoid here? Because it's going to decrease all of this inflammation. It's going to decrease this inflammation, decrease the lymphocytic infiltration and inflammation, leading to decrease in extracellular volume and eventually helping out with the exothelmos. Okay, now let's just talk about labs here. What labs are we going to see here? Because it's an hyperthyroid, so you will see decrease in TSH, increase in T4, right? Increase in total T4, and also very high yield are always the antibodies. You will see thyroglobulin, thyrotropin receptor antibody, which is called TRAB, or TSI, which is your thyroid stimulating immunoglobulin IgG. Okay, with the antibodies there, you will just think of Graves' disease. And now, importantly, where do we see? Most commonly, you will see Graves' disease in women of childbearing age. Women of childbearing age. and that is also here it is going to be present in stress where in pregnancy. Who can be pregnant is a woman of childbearing age. Okay, and that is all for Graves' disease. What do you have to remember in the Graves? You got to know that it is their antibodies, thyroid stimulating immunoglobulin antibody, which is IgG in state. Okay, it is type 2 hypersensitivity. It is an autoimmune disease in which it is triggered by either TSI, which is here, or your TR antibodies, which are your thyrotropin receptor antibody, which all of them are causing essentially what? Stimulating your TSH receptor, which is present in 3 tissues. It is present here. It stimulates the TSH receptor on the thyroid itself, on the dermal fibroblast, or on the orbital fibroblast. And on the dermal, it's going to cause mixed edema. Orbital is going to cause exothelmos, treated by glucocorticoids. Present with during stress in pregnancy, so it is associated with women with childbearing age, and the autoimmune disease is also associated with HLA-DR3 and HLA-B8. Okay, we did talk. Let's see which HLA was the other one. Hashimoto was also HLA-DR3. So B8 is only the new one, and here you also have HLA-DR3. Okay. With that, let's move on to the next thing. We have toxic multinodular goiter. Toxic multinodular, again, toxic multinodular meaning multinodules, goiter, right? Diffuse enlargement, focal patches of hyperfunctioning of the follicular cells distended with the colloid, working independently of TSH. Okay, again, so we have the follicles. We have the hyperfunctioning of the follicular cells with colloid. Colloid, they are working. So these guys are working independent of the TSH. Normally, what happens is you have the TSH, which goes down and binds to TSH receptor on the thyroid, leading to activation of the follicular cells and the colloid to make more T4, T3, right? That's normal. But here they're independently working. They don't care if you have the TSH or not. They will produce more and more T3, T4. Okay. So with that, what's going to happen is, why do we have that in the first place? Because due to TSH receptor mutations, the question is always why. Why are they working abnormally? Because there is a mutation of the TSH receptor. So they think that they got the TSH, but in fact they don't. So, but still, because of mutation, they're working continuously, right? In about 60% of the cases, this causes increased release of T3, T4, simple hot nodules, which are hyperfunctioning nodules visualized on the radioactive iodine scan, are rarely malignant. Right? Normally, you think about hot nodules, which are functioning independently. You think about malignancy here, but here we don't, because they're first of all, there's a mutation which is causing it, and you have these hot nodules, which are rarely malignant. Very important. Okay. So here, let's again mention a couple points here. Multiple nodular. So some are working, some are hot and cold, meaning hot meaning working, and some are just cold, but they're nodules. Okay, hot are working, functional, and cold are non-functional. Okay, also known as non-toxic. That's the other word. Okay. Other than that, yeah, I guess that would cover the whole thing. Okay, yeah, let's just quickly read this one more time and move on. Toxic multinodular goiter. Toxic are the ones which are working. Okay, we call them toxic because they are producing the hormone. Non-toxic, which are also known as cold, non-working, and you'll see that in the next page possibly. Here we have the focal patches of hyperfunctioning, those toxic follicular cells and colloid, independent work of TSH. They don't need TSH. They're just working with the good guys, right? Not good guys here, but normally, when you don't have supervision, you're working. That's sort of a good thing. They don't have supervision. They are working. Okay. So due to TSH receptor mutation. Okay, increased T3, T4 hot nodules are rarely malignant, and you can visualize them by radioactive iodine scan. All right. The next here is thyroid storm. Thyroid storm, it is uncommon but serious complication. A serious complication that occurs when hyperthyroid is incompletely treated or untreated, and then significantly worsen in the setting of acute stress, such as infection, trauma, surgery, presents with agitation, delirium, fever, diarrhea, coma, tachyarrhythmias, which is the cause of death. May see increase in LFTs. Treat with 4Ps. First of all, give beta blocker, example, propranolol, propyl tyrosine, PTU, and glucocorticoid, which is example, prednisolone, and potassium iodide, which is Lugol iodide. Iodide load would lead to, through Walsh-Chaikov effect, it's going to decrease the T4 synthesis, which is the Walsh-Chaikov effect. So again, we talked about thyroid storm. All you have to know, as the name suggests, thyroid storm, right? So we want to think about that you have a lot of thyroid hormone, and on top of that, you will have a lot of catecholamines. Why catecholamines? Because it is in the settings of acute stress. You have a lot of thyroid hormone being produced and a lot of catecholamines being produced in response to stress. What sort of stress are we looking for? Infection, trauma. Infection is a stress. Trauma is a stress. Surgery is a stress. Okay. With that, you have it is, let's read one more time. It is uncommon but serious complication that occurs when hyperthyroid is either you have incompletely treated the hyperthyroid, or you didn't even treat it, that led to all of the problem, which is going to show up. So you have hyperthyroid already, hyperthyroid, okay, and that would worsen setting of you have acute stress. That's going to push more thyroid and catecholamines to go high in the stress, and that is going to cause the patient to go into agitation, delirium, fever, diarrhea, coma, tachyarrhythmia. All of these things you do see as a sign symptoms of hyperthyroid. But look, agitation, delirium, okay, and fever, tachyarrhythmia, may see increase in LFTs and 4Ps. Give everything you got as a treatment. Give beta blocker, give PTU, give glucocorticoid, give potassium iodide, because that load is going to decrease T4 synthesis through Wolff-Chaikoff effect. Okay, so that is going to be all for thyroid storm. I do see a comment here. Dr. Hassab, I think I am trying to explain whatever it is here. I certainly cannot make some new knowledge. Whatever is important, I'm trying to explain that. As the time is also very important to all of us. I am trying to explain every single thing that is of high yield. Thank you. Let's move on with the next thing now. We have other causes of hyperthyroid. First of all, we have the exogenous thyrotoxicosis. Exogenous, look at that word, exogenous, coming from outside. Someone is taking excessive intake of thyroid hormone, okay, taking from outside. Now, you have to suspect in patient trying to lose weight. Wow, what a common thing, right? Patient is trying to lose weight. They're going to take a lot of thyroid from outside, and they are going to present with a thyrotoxicosis. Now, you got to differentiate. Either the patient has thyrotoxicosis, which essentially means hyperthyroid, or is the patient just taking from outside and trying to say, hey, I'm not taking it, but he's taking it to lose weight? Okay, I hope that makes sense. Second thing is you got ectopic thyroid production. You don't know where normally normal gland looks normal, but there's an ectopic thyroid production, which is stroma ovari, meaning that in the uh, ovarian tumor, you will see an ectopic thyroid production. Contrast-induced thyrotoxicosis. You gave someone contrast that caused thyroiditis, which is the Jod-Basedow phenomena. Okay, um, and then you have this drug-induced thyroiditis, which is again drug-induced amiodarone and lithium. They are going to cause thyroiditis. So we see these drugs here in thyroid, right? So just remember them: amiodarone, lithium. Okay, amiodarone has an iodine. It contains an iodine. That is how it gets into the thyroiditis. Okay, and that's going to be pretty much all for the other causes. Let's look at the causes of goiter. Goiter is diffuse enlargement of thyroid gland, right? So you have smooth and diffuse or nodular. So this goiter, enlargement of the thyroid gland, could be smooth or diffuse or nodular, meaning it will have nodules, right? So uh, smooth or diffuse or Graves' disease, Hashimoto thyroiditis, iodine deficiency, TSH secreting pituitary adenoma. Okay, in nodular, you have toxic multinodular goiter, thyroid adenoma, carcinoma, cyst. Cyst, adenoma, carcinoma, and a toxic multinodular goiter will present as nodules, meaning some part of the thyroid will be hyperfunctioning and some will be non-functioning. The ones which are going to be hyperfunctioning will be present as nodules, or in other words, hot nodules or toxic nodules, and some which are not going to be functioning. They are just going to be normal, and you will not see enlargement of that. So no goiter on that side. So that's why it's nodular, meaning let's say this is a thyroid, you have some nodules, so you will see nodular goiter instead of being a smooth diffuse goiter. Okay, that is going to be all for the causes of goiter. Now let's take a look at thyroid adenoma. Thyroid adenoma, you have benign solitary. Adenoma is benign. It is solitary growth of thyroid. Most are non-functional, meaning you have cold or radioactive iodine, cold on radioactive iodine scan. Again, because it's a benign adenoma, they're not working. So when they're not working, non-functional, they are going to be cold. Okay, that's first thing. They can rarely cause hyperthyroidism via autonomous thyroid hormone production. So these guys, although they're cold, but rarely they can start making the hormone, uh, and that will go into hyperthyroid. Simple, right? By autonomous thyroid hormone production, and that will be either called hot or toxic. Simple. So cold or non-toxic is the same thing. Hot or toxic, meaning you are producing the hormone, and cold non-toxic, you're not producing hormone. Not producing hormone. Okay, most common histology is follicular histology, arrows in A. So you have most common histology is going to be follicular, meaning you will see follicular adenoma, follicular cells being there, absence of the capsule or vascular invasion. So you will not see any capsule being invaded or being vessels being invaded by the adenoma. Okay, unlike follicular carcinoma, which will invade the capsule and the vessels. And we will talk about when we see the follicular carcinoma. Okay, that's pretty much it for this page. Let's quickly go over this and move on to the next one. Okay, here, the first one, we did talk about it in a very ample time, so I think that's pretty clear. The second thing is toxic multinodular goiter. Again, it's a hyper-functioning nodules which independently work. They don't need TSH. Why are they independently working? Because of mutation in the TSH receptor. Uh, okay, hot nodules will be seen on the radioactive iodine scan, and they are not malignant. Thyroid storm, it is when you already have hyperthyroid, which is either untreated or incompletely treated. With that, you have stress that increase catecholamines. It leads to agitation, delirium, fever, all of this. Tachyarrhythmia is high yield because it causes death. Okay. You treated with whatever you got. What do you got? You got beta blockers, you got PTU, you got prednisolone, you got potassium iodide, everything you just give because it is a storm and you want to inhibit that storm. Okay. Other causes are going to be either you taking something from outside and leading to hyperthyroid that is normally seen in weight loss, or there's an ectopic thyroid production, which is seen in the stroma ovari, or you give patient a contrast which causes hyperthyroid, which is due to the fact that it went into jod based out phenomenon. Okay. And then you have drug induced thyroiditis. You gave a drug that causes thyroiditis, amiodarone lithium. Causes of goiter is going to be either smooth or either nodular. The ones nodular are, you can think about only one disease being here. That's going to be toxic multinodular goiter. Other than that, you think about adenoma, carcinoma, cyst. In the smooth, just think about all the diseases that we talked about. For example, Graves, Hashimoto, iodine deficiency, TSH secreting, pituitary. Okay. Thyroid adenoma is a benign growth of thyroid, which is non-functional, but could go into functional, leading to formation of hyperthyroid uh, uh, hormones being produced in the hyperthyroid. Uh, and when it does produce hormones, it's called hot or toxic. Simple. Histology is going to be follicles which are not going to invade the capsule or the vessel, unlike follicular carcinoma, which will invade all of this, and we will talk about that on the next page. Okay, with that, let's just take a 5 minutes break, and we will get back. And if you have any questions, you can always write on the chat, and we'll be happy to answer. All right, welcome back. Let's start. Let's talk about thyroid cancer. Thyroid cancer. It's typically diagnosed with fine needle aspiration, FNA. It is treated by thyroidectomy. Okay, simple. Complication of surgery. If you were to go into thyroidectomy, what are the complications? They include hypocalcemia, because when you were doing thyroidectomy, you also remove the parathyroid glands, and that causes hypocalcemia. Okay, transection of the recurrent laryngeal nerve during the ligation of the inferior thyroid. We did talk about it in anatomy in the very first pages, that if you were to transect the inferior thyroid artery, your essentially there's a propensity that you could transect the recurrent laryngeal nerve, and that will cause dysphagia, dysphonia, hoarseness. Okay, and with the injury to the external branch of the superior laryngeal nerve, there is during ligation of the superior thyroid vesicular pedicle, uh, there is a loss of tenor voice, usually noticeable in professional voice user, meaning there's going to be a loss of low pitch sound. Low pitch sound. So with one, now important thing is with the recurrent laryngeal nerve, which supplied every muscle, and with the external branch of superior laryngeal nerve, this only supplied cricothyroid muscle. So if you were to knock out superior laryngeal, you're knocking out your cricothyroid. So all you're losing is the low pitch voice. If you were to knock out the other one, which is the recurrent laryngeal nerve, you're essentially knocking out all the muscles, and that is going to cause hoarseness, dysphonia, and dysphagia. Again, high yield concepts. If you want to know more on this, go back on the first page, where's the thyroid formation and everything. I believe it's the first page. But again, that's very important. The next thing is going to be the actual cancers. First cancer we have is called papillary uh, papillary carcinoma or papillary carcinoma. It is most common. Here we will have empty appearing nuclei with central clearing, high yield, orphan and eye eyes. Let's take a look at picture A. What do we see here? We have orphan and eye, so empty appearing, as the name suggests there. And look here, it says empty appearing nuclei. So if you look at the nucleus, they look empty, right? And that's exactly what we have. Empty appearing nuclei with central clearing, right? Here we have central clearing and empty appearing nuclei. And those are specifically named as orphan and eye eyes. Okay, that's one thing with the papillary carcinoma. Second thing, you will see pneumoma bodies. Third thing is nuclear grooves. So the mnemonic they have is Papi and Mama adopted orphan and eye. So Mama for pneumoma bodies. Okay, orphan and eye is orphan and eye, and Papi is for the papillary or papillary carcinoma. Okay, there's increased risk. High yield is increased risk with RET or PTC rearrangements and BRAF mutation. Okay, increased risk with RET, high yield, and your BRAF mutation. Childhood irradiation is also very high yield. Okay, now family history. Something about family history here. There's going to be a positive family history with thyroid carcinoma. with thyroid carcinoma. And that will lead to, and if the childhood, leading to childhood irradiation, uh, just remember there's a positive family history. If there's a positive family history, you think about childhood, uh, you think about BRAF mutations, and leading to childhood irradiation. Okay, that's one of the cause of it. Now, importantly, you have one more thing important is going to be it is characterized by this papillary carcinoma. It is characterized by branching papillary structures with concentric calcification. So let me write this down. Branching papillary structures, okay, with concentric hypertrophy. My bad, not concentric hypertrophy, but with concentric calcification. Concentric calcification is Joyce-Mama bodies. Okay, so because now let's go with the names. Papillary structures, right? So what are papillary structures? They are going to be having a papillae. So branching papillary structures with the Joyce-Mama bodies, which is your concentric calcifications. Okay, that is important. Other than that, you will also see palpable lymph nodes with it. Palpable lymph nodes. Let me erase this part. Palpable lymph nodes. Okay. Now there's a T cell variant which is seen in elderly, which has the worst prognosis. Okay. Which is characterized by follicular hyperplasia by the tall epithelial cell, but this is of lesser yield, so don't worry about it. The most important thing here that you have to know is going to be how the nucleus are going to appear, right? So let's just think about those at a moment. So you will see large cells with nuclei containing a dispersed chromatin. This is another way of explaining the same thing of an empty pairing nuclei. Okay, so in large cells with nuclei containing dispersed chromatin, giving it a ground glass appearance. So it will give a ground glass appearance. Okay, which is again same thing as saying empty appearing nuclei with central clearing. You can see both on the histology. And intranuclear grooves. So nuclear grooves, specifically, we're looking at intranuclear, within the nucleus. You will see grooves. Okay. So what is small body again? It is just a calcium deposition. So concentric calcium deposition leading to formation of small bodies. And that is going to be all for papillary carcinoma. The next thing we have, and I'll read all of these and then we'll go through them once we're done with this page. So next we have the follicular carcinoma. Follicular carcinoma, it has a good prognosis. It invades the capsule and the vasculature, unlike adenoma, which was not invading the capsule and not invading the vasculature. These guys are uniform follicles. Let's look at picture B. You can see follicles, but they're uniform. So uniformity is there. Follicles being uniform. Okay. Now, importantly, they are going through heterogeneous spread is common. So if you think about carcinomas, generally, the carcinomas, they like to go through lymph nodes, right? Or lymphatics. Carcinomas, they like to go, the cars run on lymphs, right? That's the way they do it. But this is an exception here, that the carcinoma is actually going through heterogeneous spread by the blood. Okay, that is there. And then it is associated with RAS mutation, okay, and PX8 and PPAR gamma translocation. RAS mutation, high yield, and also PAX8 and PPAR, also translocation, also high yield. FNA, which is fine needle aspiration cytology, may not be able to distinguish between follicular adenoma and carcinoma. And why is that? Because if this is your thyroid gland, you stuck a needle in, it's going to take up the tissue. With this, you don't know if this the carcinoma invaded the capsule or the nearby vessels or not. All you're looking at the cells, and here the cells are uniform, right? So you would not know, is it due to the fact that you have adenoma or carcinoma? Simple as that. Okay, because you're just stucking in a needle, taking out a tissue at that specific location. You would not know. Did it invade or no? Did it invade the capsule or not? Okay, and that is also very high yield. FNA cannot distinguish between follicular adenoma and carcinoma. Okay, and with that, I guess that's pretty much all we have for follicular carcinoma. Now let's talk about medullary carcinoma. Now, medullary carcinoma, again, it's a medulla, means the middle part, right? So what do we have? We have the follicular cells in the mid, right? So what we will see is we will have parafollicular C cells, which normally produce calcitonin. Now we will see, because it's a carcinoma of those cells, we will see sheets of polygonal cells in amyloid stroma. Whenever you think about amyloid, it's going to stain with Congo red. Congo red stain will be there, will be present. If you were to do a Congo stain, you will see that. And it is associated with MEN2 high yield and MEN2B, which we will talk about. And red mutations, so medullary carcinoma, instead of calling it medullary carcinoma, medullary carcinoma. If it makes sense, then you can just think of these, but it's going to come up anyways. Okay, now what do we need to know here? So first of all, it's a this, because it's a medulla, right? So it is a neuroendocrine tumor. Neuroendocrine. It's a neuroendocrine tumor, which is going to rise from the medulla, which is the malignant proliferation of the parafollicular C cell, produces calcitonin. And these parafollicular C cells, because they are going to the malignant transformation, you'll see sheets of polygonal cells. Again, sheets of polygonal cells in amyloid stroma, high yield, okay, and which would stain with Congo red. So the mnemonic they have here is CC, MEN2A2B, so medullary carcinoma. And with the C's being there, just think about Congo red and C, calcitonin. So when you have, one more thing is going to come up, as when you increase a lot of this calcitonin, right? I mean, there is going to be some actions of it. So what are the actions of so much increased calcitonin levels? Well, it is going to give you hypocalcemia, via increased renal excretion of calcium. That's one thing. Second thing is going to deposit, this calcitonin is going to deposit within the tumor as amyloid. So which we talked about as an amyloid stroma. Okay, that is there. Now, there's a couple causes we did talk about associated with RET mutations, right? Now, RET mutations, if RET mutation is positive, then do prophylactic thyroidectomy. So if you see a RET mutation positive in MEN2, MEN2B, 2A or 2B, if they are due to the fact that you have the RET mutation, then you would just go for thyroidectomy, because it will develop MEN2A, 2B with RET mutation. It will develop medullary carcinoma too. So to do prophylactic thyroidectomy, you're trying to save the patient from going into medullary carcinoma. That's one important thing. Second important thing is going to be that this medullary carcinoma itself, it could be sporadic, which is most of the time sporadic, or also it could be due to familial cause. So let's say sporadic is about 80% and familial is about 20%. And familial is the part. Now, Now you think about men 2A, 2B, but the familial, which is men 2 and men 2B, it is a part of men, meaning men 2A and 2B, and an or RET mutation. So it's only 20%. The rest is just sporadic. Okay. Again, what did I talk about? Let's go back, revise the whole thing. Well, I said with men 2A, 2B, due to RET mutations, you are going to prophylactically remove thyroid, which is known as thyroidectomy, because essentially it is going to go into medullary carcinoma. So you remove it before it develops. One thing. Second thing I talked about, that all of this is only 20% of medullary carcinoma. But if there is RET mutation, there is development of medullary carcinoma, and that's why you do thyroidectomy. I hope that makes sense. Now, if this is only 20%, what about the rest of it? That rest of the 80% is just going to be sporadically formation of medullary carcinoma. Okay. With that, let's talk about last thing here, which is the RET. What is RET gene itself? RET gene, it codes for, let's just mention it here, it codes for membrane-bound tyrosine kinase receptor, TK receptor, tyrosine kinase receptors, which are involved in, tyrosine kinase receptor, which are involved in cell cycle regulation. That's one thing. These guys, RET encodes for this. Okay. So if you have a mutation in RET, what is going to happen is that you will have the constitutive activation, which means always active, of that tyrosine kinase receptor, and which were normally doing the cell cycle regulation. Now they're constitutively active, meaning they are going to have continuous activation of TK, which is tyrosine kinase receptor, leading to unregulated cellular proliferation. And that unregulated cellular proliferation will lead to formation of carcinoma. Okay. And that is all. And this was just, I guess, an extra detail for RET, but important to understand what is RET. It's going to come up in men 2A, 2B, so important RET mutation. You understand the normal physiology there. Now let's take a look at picture. You can see on picture C, you have a lot of amyloid here. Look at all of this amyloid deposition, right? Amyloid deposition in the stroma. Okay. What else we can have here? And these are the malignant C cells. Malignant C cells. And that is all for medullary carcinoma. And the next thing we have is called undifferentiated anaplastic carcinoma. This one is older patient, older meaning greater than 60. And it's going to present with rapid enlargement of neck mass. Okay. Now let's compare this while we're talking about it. Compare this versus Riedel, right? Riedel thyroiditis. This is old patient. In Riedel, we said it's going to be young patient. Now, what is the common feature? Enlarging neck mass. You would also see enlarging neck mass in Riedel. Okay. What is also common? They will compress. There is going to be compressive symptoms. For example, dyspnea, dysphagia, hoarseness. You will see that also with Riedel. Okay. Very poor prognosis. Then you have typically composed of pleomorphic cells with frequent mitosis. Look at picture D. This does not even look like thyroid, does it? Question mark. Is it even thyroid? Not thyroid, right? That is why it is an undifferentiated anaplastic carcinoma. The cells there, they don't even look like thyroid. That is why you have poor prognosis. That is why you see frequent mitosis there. Okay. And it's going to arise either de novo, which means on its own, or most often arise from the de-differentiation of pre-existing follicular or papillary thyroid carcinoma. So from follicular or papillary can eventually go into undifferentiated anaplastic carcinoma. But most often it arises, most may arise de novo, but most often arises from the dedifferentiation of these thyroid and follicular carcinomas. So let's add one more thing here. On cytology, what do we see? Now, how the cells are going to be present? Well, there are going to be, you have pleomorphic cells, irregular giant cells, and biphasic spindle cells. Pleomorphic cells that will have irregularity, so irregular giant cells, and biphasic spindle cells. That's one thing. Now, more than this, the important thing is that these cells do not resemble normal or some sort of normal epithelial thyroid follicles. They don't resemble nothing like thyroid. So again, these cells won't resemble anything that will normally be present in thyroid. Okay. And that is why we call it anaplastic. With that, let's just review the whole thing and move on to the next part. Okay, thyroid cancer. We can diagnose the thyroid cancer by FNA and treat it by thyroidectomy. But we have to figure out one thing. If we are doing thyroidectomy, there are a couple of complications. First complication is you could remove the parathyroid gland, leading to hypocalcemia. You could remove or you could cut down the recurrent laryngeal nerve, which leads to hoarseness. Or you could cut down your superior laryngeal nerve, which will lead to loss of your tenor voice, which is going to be loss of your pitch, and it is used in professional voice. So those are some complications of your thyroidectomy. Now, couple carcinomas. First of all, we have the papillary carcinoma. Couple features of papillary carcinoma is going to be your empty appearing central, empty appearing nuclei with central clearing, with samoma bodies, which are essentially your calcium depositions, and intranuclear grooves. These couple things, if you look at it, if you see in the question stem, you will think about papillary carcinoma. The mutations are going to be your RET mutation. Again, RET also shows up here at the medullary carcinoma. And also you have a BRAF mutation. Okay, papillary carcinoma, most prevalent, palpable lymph nodes, high yield, and has a good prognosis. Now, the follicle carcinoma means the follicles. There's a carcinoma. There is a tumor of those follicular cells. The important thing with follicular adenoma and carcinoma is that carcinoma would invade, and the adenoma would not invade. What are they invading? They're invading the capsule and the vasculature. Okay, and follicles are going to be uniform follicles. Important thing is going to be this is going to have an homogeneous spread, but this is not seen with the carcinomas. Normally, the carcinomas, they travel through lymphs. The car goes in lymphatics. That's the carcinoma, right? But here it's different because this carcinoma goes through lymph. So there are four, let's just actually mention it here. So there are essentially just four carcinomas that go through blood. Those are going to be your, first of all, we just talked about the first one, which is follicular carcinoma. The second is going to be your renal cell carcinoma, and that is going to go into renal vein and then eventually blood. The third thing is your HCC, which is hepatocellular carcinoma. Again, goes through the hepatic vein and goes to blood. Fourth one, the last one, is going to be your choriocarcinoma, which goes straight into the blood. Okay, so RCC, HCC, choriocarcinoma, and follicular carcinoma, they go through blood. All the rest of carcinomas, they go through lymph. So CARs go through lymphs. That's going to be important. Okay, other than that, Um, but now, how do you differentiate between adenoma versus carcinoma? Well, the differentiation point, if you do FNA, which is fine needle aspiration, all you're looking at is just one side of cells, right? You will see cells there. They are all uniform follicular cells. But so you cannot differentiate these two things based on FNA. Fine needle aspiration would not distinguish between follicular adenoma and carcinoma. Okay, for that, you have to cut down the whole thyroid from the straw, which is the capsule itself, to see if it invades the capsule or not. Okay. The second point is going to be for your medullary carcinoma. Medullary, with all the C's, and first of all, medullary is associated with MEN2A, 2B. MEN2A, 2B are going to MEN2A, 2B are going to have RET mutation. What is RET gene itself? Well, it encodes for tyrosine kinase receptor that then causes cell cycle regulation. So if you have a mutation, it leads to constitutively active RET, which essentially means there is always RET is always active. That means you're always making tyrosine kinase receptor, which is always going into cell cycle. So there is unregulated cell cycle growth, and that essentially causes carcinoma. Okay, with the medullary, you are going to think of sheets of polygonal cells in amyloid stroma. Okay, polygonal cells with amyloid stroma. This is C cells parafollicular. Other sign and symptoms of this parafollicular C cells is going to be hypocalcemia, because you're going to lose the calcium in the renals, right? So hypocalcemia, that's one point. Second point is going to be your amyloid stroma, which is going to be stained by Congo red. Okay, that's going, and prophylactically, when you have MEN2A, 2B, prophylactically you do thyroidectomy. Okay, and that is all for medullary. The last one here is going to be your undifferentiated anaplastic. As the name suggests, this is undifferentiated anaplastic carcinoma. These cells do not look nothing like, they have nothing in common as the thyroid. Look at this picture. Nothing in common with thyroid tissue. Okay. And that is why they have very poor prognosis. And they are going to, again, go into the local structures just like Riddle. But here it's an older patient. In Riddle, you have a younger patient. And again, it's going to be enlarging neck mass. Both have enlarging of the mass, compression systems, symptoms, for example, dyspnea, dysphagia, or hoarseness. And it is composed of high-yield pleomorphic cells, which are undergoing frequent mitosis here. And it might arise de novo, but most commonly arises from the pre-existing follicular or medullary carcinomas. And that is going to be all for thyroid cancers. Let's take a break, and we will move on to the next page. Let me put up the timer. Maybe 10 minutes, okay. Okay, welcome back, guys. All right, so there's a question on this. Okay, yeah, if you cannot go for FNA, as I said, FNA would only look at one thing. What you could do is you could have a full thyroidectomy to check up if the capsule is invaded or not, or you could do a lobectomy, one lobe of the thyroid being removed, and see if there is an invasion or not. But FNA would not tell. I hope that answers the question. Okay, now the next thing we have here is okay. Now let's talk about here. We have the diagnosing parathyroid disease. Okay, there's a nice chart here, a graph here, or so look at the calcium levels here. We have a normal calcium level that is going to be your the normal is 8.4 to about 10.2. On top of my head, that's what I think. But if you have a new ones, that's what I think right now. 8.4 to 10.2 is going to be the calcium levels normal. Okay. So let's take a look at hypoparathyroid, in which you have lower side of calcium. So this is your calcium and this is your PTH. Hypoparathyroid, right? So parathyroid is basically saying you have low PTH. Yeah, you can see there's a low PTH here, right? And you also have low calcium. Low calcium. And why would you have this? Well, either you have removed the parathyroid gland, or there's an autoimmune destruction of the parathyroid gland. Essentially, you don't have parathyroid gland. Okay, that's going to give you hypoparathyroidism. Simple. Now, looking again at the same spectrum of lower calcium, look at here. We have a low calcium, but we have high PTH. So let's just write it down. Increasing PTH, because look at the levels, 250 PTH and the low calcium, right? So here you have the secondary hyperthyroidism. And why secondary? Either you have vitamin D deficiency, or you have calcium intake low, or you have CKD, okay, chronic kidney disease. All of that, certainly you're going into, all of these are causing low calcium causing increased levels of PTH, parathyroid hormone. Okay, that's the hyperparathyroid. Secondary, due to secondary thing. What is secondary thing here? Low calcium. Okay, now we're going to change the spectrum. We're going to look at, we have a higher calcium. So here, PTH independent hypercalcemia, we have high calcium, first of all, because we can see the levels here, they're higher. So high calcium, and PTH is low PTH, right? So PTH independent hypercalcemia. Why? Because we have a low PTH, but we have high. So whatever the calcium we're getting is not due to PTH, it's independent of PTH. Okay. So excess calcium intake that you either you got it from outside, cancer, or increase in vitamin D, essentially opposite of all of this. Just remove the CKD2 cancer, and all you have is increase in calcium and low PTH. Now, with this, look at the primary hyperthyroidism. Now, with the primary hyperthyroidism, you have you have increased in your PTH, as well as increase in calcium. So in which things we can have this? In the hyperplasia of the parathyroid, in the adenoma of the parathyroid, in the carcinoma of the parathyroid. Essentially, normal function of parathyroid is to get increase more calcium. So this is exactly what we are seeing here. Okay. Now, lastly, tertiary hyperthyroid. In the tertiary hyperthyroid, you have again same sort of a scenario where you have increase in PTH, but way too much high of PTH, and you have increase in calcium, and that isn't seen in CKD, your chronic kidney disease. Chronic kidney disease, and this will come up in the next pages. So with that, let's take a look at now all of these in details. So you have hypoparathyroid, so low PTH. question, why? Why did we have this low PTH? Well, it is either due to injury to the parathyroid gland, or due to their blood supply, usually from the thyroid surgery, or there is an autoimmune destruction of the parathyroid gland, or there is going to be DiGeorge syndrome. Okay, all of these are the causes of having low PTH. Okay, the findings with the low PTH, what's going to happen when you have low PTH, you're going to have a low calcium. The findings are going to be of low calcium, tetany, hypocalcemia causing tetany, and hyperphosphatemia, because if you recall, PTH was phosphate dumping hormone, right? Phosphate trashing hormone. So when you don't have PTH, your phosphate is going to be high. Okay. So now two things we will see. We will see neuromuscular hyperexcitability, one thing, and which is essentially is going to go into muscle spasm. So let's just write that: neuromuscular hyperexcitability, excitability. Here you will have Chov-Stek sign and a Trozo sign. Okay, what is Chov-Stek sign? Well, when you tap the facial nerve, where would you tap on the facial nerve? So anterior to the ear, anterior part to the ear. When you tap on the face, on the facial nerve, for example, tap the cheek, it's going to contract the facial muscles. Trozo sign is when you have an occlusion of the brachial artery, when you put the BP cuff on. Now that cuff the tricep leads to carpal spasm. So again, when you occlude the brachial artery by putting on the BP cuff the triceps, leading to carpal spasm, or in other words, you can call it carpopedal spasm. So let me write carpopedal spasm. Okay, so these two things are these are the muscle spasm associated with neuromuscular hyperexcitability. Okay, that is seen with the hypocalcemia. Okay, again, with hypocalcemia, you are going to see tetany, right? That is going to cause spasms. Which spasms? Chov-Stek sign, Trozo sign. Okay, muscle is, first of all, is going to first you have twitching of the muscle, hyperexcitability, and also one more thing is going to be with low calcium is going to cause increase in QT interval. If you recall, we talked about how low calcium, low magnesium will cause increase in QT intervals. Okay, so that is with all of this. Now, one extra thing that you will see when there is low calcium, hypocalcemia, here you also see perioral paresthesias. Perioral paresthesias, which is basically you will have numbness, tingling periorally, and paresthesias periorally. Okay, in the labs, let's write the labs here. Where do I write? Let's just write it here. Labs. In the labs, we have what we will have low PTH, which is the first problem, right? That is going to cause low calcium. That is going to cause increase in phosphate, right? And yeah, that's going to be all with all these signs and symptoms of hypocalcemia. Okay, now let's talk about the second thing here. We have pseudo hypoparathyroidism. So we have hypoparathyroid, which is proper hypoparathyroid. Now we have pseudo false hypoparathyroid type 1 and type 2. So let's talk about, I don't know where the type 2, but let's talk about this one right here. So hypoparathyroid type 1A is an autosomal dominant maternally transmitted mutation which is imprinted GNAS gene, which is GNAS S1 inactivating mutation, which is coupled to PTH receptor that encodes for the GS protein. So this GNAS, GNAS1 or GNAS gene encodes for what? Encodes for GS coupled alpha 1 subunit. Okay, so now when you have a mutation here, you cannot encode for normal GS alpha subunit. And if you recall something, and that is that the PTH, it works on its receptor, and that receptor activates your GS cyclic adenylate GS protein, which then goes and activates your adenylate cyclase, which then increases cyclic AMP, right? So now since you have a problem here, nothing else is going to work since you have a problem here. Where's the problem again? The problem is in the GNAS1 or GNAS gene, which is encoding the GS protein alpha subunit. So when you have a problem in the GS protein alpha subunit, there's an inactivation of adenylate cyclase. So when PTH binds to its receptor, it leads to end organ resistance, meaning no matter how much PTH binds to this guy, nothing is going to work because there's a mutation here, right? That's exactly what's mentioned there, right? It's going to cause resistance where in the kidney and the bone to the PTH. If you recall, the PTH was working on the bone and the kidney itself, and it was working on GI through vitamin D. I don't know why my pen is lacking here, but vitamin D, it works on GI through vitamin D. So no effect on GI, increased absorption of calcium and phosphate, but only problem in the kidney, which it directly works on. Wherever is the direct work of PTH, that's where the problem is. Now, physical finding is going to be Albright hereditary osteodystrophy, which is essentially saying you have a shortened fourth and fifth digit right here. Shortened fourth and fifth digit, right? Again, with short stature, round face, subcutaneous calcification, and development delay. So think about this: so development delay, short stature, fourth and fifth digits are being short. It's called Albright hereditary osteodystrophy. Okay, with the labs, with the pseudo hypoparathyroidism. Why is it called pseudo? Because it is hypoparathyroid, but you have increase in PTH. Why is it hypoparathyroid? Because essentially PTH is not working on its target tissues because there's resistance, because you cannot make that alpha subunit normally of the GS protein. So there's a resistance. That's why you have increased PTH, but they cannot work on their organs, causing low calcium and again high phosphate. Okay, because although you have PTH, but it is not working. Okay, that is why you will see low calcium, high phosphate. Now compare this with something known as pseudo hypoparathyroid. So we have pseudo and pseudo hyperparathyroid. Here, why it's called pseudo, I'll talk about that, but let's read first. Here again, autosomal dominant. Both are autosomal dominant. The pseudo one is from maternal mutation, and pseudo is from paternal mutation. Again, impaired GRAS gene. But here, now the issue is there is no end organ resistance without end organ resistance to the PTH. Why? Because normal maternal allele maintains the renal responsiveness to PTH. So here we had a problem in both the kidneys and the bone. Here we don't. We don't have a problem. Specifically, they mentioned here the kidneys. Okay, so physical findings is going to be same as Albright hereditary osteodystrophy, which is again all of these are same. Short stature, development delay, fourth, fifth digits are going to be small. Okay, the labs, you have a normal, everything is normal here in the labs. Okay, so normal PTH and calcium, and that is why it's called pseudo, meaning you have normal labs, meaning normal PTH, normal calcium. So pseudo, it's not pseudo means cancel each other out. So just think about it that way. Okay, here it cancels out, everything is normal. Pseudo cancels out each other, everything is normal. So if you look at the labs, you have PTH normal, calcium level, but still you will see Albright hereditary dystrophy. Okay, that's one. Okay, let's add one more thing here. With this, first of all, let's compare this. Pseudo hypothyroid, pseudo hypothyroid. Both will have Albright hereditary osteodystrophy. But what they will not have is pseudo will not have end organ resistance. Pseudo, just the top one, pseudo will have end organ. Again, what is end organ resistance? Let's mention that again. End organ resistance is basically when the PTH cannot work on its targeted tissue, for example, kidney, for example, bone. Why cannot it work? Because there's a mutation in the GS alpha proteins, alpha protein subunits. That's why it cannot work. Okay. And so here you will have end organ resistance, meaning you cannot work. But here you don't have any end organ resistance because maternal genes are going to respond to your PTH. Now we have to know which one is coming from maternal side and which is coming from paternal side. So the mnemonic is going to be something like when you're talking about pseudo, right? Who can fake it more, a male or a female? Okay, paternal, a male would fake it more, pseudo. Okay, a mother, maternal, would not fake. I mean, this is just a mnemonic, guys. Okay, a mother will not fake it more, so she's just going into pseudo. Okay, pseudo, paternal side of the mutation, gene as mutation is coming from the paternal side. From the maternal side is only gene as mutation coming from, again, maternal side. So, I mean, if you have a better mnemonic, happy to share it here, But what else we can think of? Okay, yeah, one more high yield tie-in is going to be these fingers, okay? These two fingers, fourth and fifth digits are going to be short, but tell me disease in which you just have the fourth finger being shortened, fourth finger or fourth digit being short. And that specifically you will see in Edwards syndrome. Edwards syndrome, and that is in biochem. We will see that. But just here, we're trying in everything that we can. Okay, you see one finger being shortened, which is just the fourth finger. That is seen in Edwards. Fourth and fifth, high yield Albert hereditary osteodystrophy. Okay. With that, I guess I made everything pretty clear. Now, one thing about DiGeorge syndrome here is going to be, again, you have a neural, let's just write it. So you have a neural crest fails to migrate. When they migrate, where are they migrating to? They are migrating normally to third and fourth pharyngeal pouch to form the parathyroid gland. So, but when they will not migrate, they will cause PTH deficiency, and they will not make the thymus itself. So in DiGeorge syndrome, you will also have T cell deficiency. Okay. With that, let's take a look at this table. And it's going to clear up most of the things. So first of all, we have the vitamin D deficiency. In vitamin D deficiency, first of all, we look at vitamin D. We look at vitamin D. Why is it high? Okay, inactive vitamin D. Look at this. It's low, right? So this is active. Okay, this is active part of vitamin D. This is inactive part of vitamin D. But when you get the vitamin D from outside, it's always inactive, and 1-alpha hydroxylase acts on it to make it active. So we are essentially looking at what we have from outside. So it is low, right? So that is vitamin D deficiency. When you have vitamin D deficiency, you will not be able to reabsorb calcium. That's going to be low. You will not be able to reabsorb your phosphate. That's going to be low. Because you have calcium low, it's going to stimulate PTH. And because PTH is going to stimulate osteo, what does PTH stimulate? Osteo? You got it right. Osteoblasts. And indirectly, those osteoblasts will activate those osteoclasts. So when you activate the osteoblast, blast is the mnemonic here is going to be basic environment. That basic environment is your ALP, alkaline phosphatase. So because you're activating osteoblast, the clinical markers are going to be ALP being high. And the mnemonic is, again, I mentioned B for blast, B for basic environment. Basic is given by your alkaline phosphatase. Okay, that's all with the vitamin D. Now, looking at the next one is secondary hyperthyroidism, CKD. You have hyperparathyroidism. Secondary hyperparathyroidism. Where's the problem? Well, the problem is that you have CKD, right? So where would be the problem be? That you have increase in PTH with increase in phosphate. So the problem is here in CKD. You cannot remove the phosphate. When you cannot remove the phosphate, all that phosphate is going to bind to the calcium, causing low calcium, right? When you get the low calcium, it's going to stimulate your PTH. Again, PTH stimulating osteoblast, increasing ELP, right? And your vitamin D is just low because, again, where does it activate? Where is this activation occurs? In the kidneys. You are already in CKD. You cannot activate in the PCT, proximal convoluted tubules. You cannot activate your vitamin, inactive to active vitamin D. That's why you have a low vitamin D. That's what the secondary hyperparathyroidism, which essentially means you have increase in PTH and low calcium and high phosphate. Now you have hypoparathyroidism. Hypoparathyroidism, again, same thing, but low with the name hypoparathyroid, low PTH. When you have low PTH, you will not be able to dump phosphate to increase phosphate. Low calcium, that is which is stimulating low hypoparathyroidism. Why would you have low calcium here? Let me think. Oh yeah, here, because you don't even have PTH. When you don't have PTH, you will not be able to reabsorb calcium. Simple. Look, again, it's simple. Look at the name hypoparathyroid. Hypoparathyroid, you don't have parathyroid. When you don't have parathyroid, you cannot reabsorb calcium. When you cannot reabsorb calcium, you're not going to have calcium, and your phosphate is going to be high. Simple, right? And here, this could be normal or decreased vitamin D. Pseudo hypoparathyroidism. Pseudo hypoparathyroidism is you have the first one, right, with the mother. So it's a pseudo hypothyroid. Why is it pseudo? Because you have, if you look at the PTH level, it is high. It is high. You look at your phosphate level, it's also high. And why is that? This is similar. If you look at these, look at this: phosphate high and calcium low. Only difference is going to be your PTH level itself. Why? Because in the pseudo hypoparathyroidism here, you have resistance. This PTH cannot even work on its target tissues. So the body is not even getting, let's say body is not even getting that PTH because it's not working, right? It is malfunctioned. That is why although you have increased in PTH, but it functions like no PTH. I hope that makes sense. Okay. And which organs are we specifically are going to be resistant? It's going to be in the kidneys and the bones. Okay, kidneys and bones. Okay, and that is all. So let's just revise the top part. This is very high yield, guys. Let's revise it quickly and move on to the next. Important things, okay, just important things. Hypoparathyroidism, you have low PTH. Why don't they put the labs here? I have no clue. But in the question, they put every lab. So I don't know why. But low PTH, simple. Hypoparathyroid, low PTH. When you have low PTH, you are going to hypocalcemia. That hypocalcemia, all the signs and symptoms are due to the fact that you have hypocalcemia. Tetany, Chopstick sign, Trozo sign. Chopstick is all about tapping the cheek, leading to contraction of the facial muscle. Trozosine is all about tricep, tricep, where the BP cuff goes, causes carpopedal spasms, tetany, and hyperphosphatemia, and that also hypoglycemia can lead to seizures, can lead to perioral paresthesias, and all that, right? Now, the second thing is going to be your pseudo. A mother is a pseudo, and a father is a pseudo. So from mother is transmitting a mutation in the GNAS gene. In the pseudo, a father, a paternal gene is transmitted that GNAS mutation. Okay, uh, and when the paternal is being pseudo, mother is always there to help. So you have a normal mother allele, which will try to save the thing on the kidney, so you don't have much of effect. So that is why you are going to get everything normal. Okay, and that is all for these things. Okay, with that, let's take some break. Um, and again, guys, when there is a break, take that time to read through it one more time. Okay, uh, take that opportunity to actually go ahead and read it. And if you got any question, you can always type in there, and either me or anyone who's in the chat, anyone can answer. But take the time to read. There's going to be 5 minutes break, and we'll be back. Actually, make it 10, and we'll be back in 10. since we just have 1 minute left, I want to talk about some features that we have on the chat. Okay, so if you so someone has already volunteered to be on cam, so you will see them on cam now. I don't know when they're going to start, but they will start soon. What one of the features that you can do online, if you were to go on this, let's say live sessions, which is like study with me type sessions, and you can see how much you have studied by putting in these prompts. For example, exclamation mark study. This is how much you have studied. You can do individually. It's going to tell you individual basis how much you have studied at that username. Okay, so study or I hours, meaning exclamation mark hours. You can see whoever studied how much, and you can also do let's say top hours. Let me write this. So who has studied the most? Top hours. And with that, you can see it will come up. And there are a couple other nice features which what I will do is I'll just post it in the comment section or in the description section. So it's pretty nice. These bots are doing a wonderful job. So let's get back to our session. Let me close this out. Okay, with this, let's move on to the next one. And that is hyper. So we talked about here in this page, we talked about everything with hypoparathyroid. Now we're going to shift gears towards hyperparathyroid. Okay, so let's talk about each one of the diseases here. All right, now let's start with hyperparathyroid. The first thing we have is primary hyperparathyroidism. Okay, now the primary hyperparathyroidism, it's usually due to parathyroid adenoma or hyperplasia, that you have the adenoma who's making the PTH, hyperplasia, they're also making the PTH. It essentially is going to cause hypercalcemia. And with the previous one, we talked about everything with hypoparathyroid, low PTH, low calcium, right? Which is here. And now with the hyper, we're going to think about everything with high. So increased PTH causing increased calcium. Okay, with that calcium also goes in urine, hypercalciuria. When it goes in urine, it's going to form stones, so renal stones. Also going to cause you polyuria, which are stones, and hypophosphatemia with increased PTH, as PTH is a phosphate trashing hormone. It's going to trash that phosphate, so you will have hypophosphatemia. With the labs here, increased PTH, increase ALP, increase urinary cyclic AMP. Now, this is very high yield. We did talk about ALP. Let's just mention it one more time. Again, PTH works through osteoblasts. Blast work in a basic environment that is given by ALK phos. So B for blast, you can say B for basic. Basic is ALK phos or alkaline phosphatase. And that is if you have increased ALK phos, you can just think of that your activity of osteoblast has increased. Why? Because PTH does not directly work on osteoclasts, right? It stimulates osteoblast, which in turn stimulates osteoclast, which in turn causes increased calcium release from bone, right? Bone resorption. Where is my eraser? Okay, here. And now increased urinary cyclic AMP, let's talk about this one. If you recall, again, PTH works through which receptor? Well, it works through your GS coupled protein receptor, which in turn causes what? Which in turn causes converts, well, is through adenine cyclase, and that leads to ATP conversion into cyclic AMP, right? And then when you have a lot of PTH stimulating all this pathway, causing a lot of cyclic AMP, that cyclic AMP is going to be seen in urinary, in urine. So increased urinary cyclic AMP. Most often it is asymptomatic, may present with bone pain. Bone pain because a lot of that osteoclast or reabsorbing bone, essentially leading to bone pains. Okay, weakness, constipation, groans, abdominal flank pain, kidney stones, acute pancreatitis, neuropsychiatric disturbances like psychiatric overtones. So mnemonic is stone, thrones, bones, groans, and psychiatric overtones. This is all due to the fact that you have high calcium. So it's not necessarily that you just see it with increase in PTH, but whenever you have high calcium, you will see all of this: stone, thrones, bones, groans, and psychiatric overtones. Okay, that is important. What else we can think of? Um, you have increase. I mentioned about increase in cyclic AMP in the urine, which essentially means you have increase in PTH, which works on its receptors, and that just goes and get excreted into the urine. Question is, why do we have pancreatitis here? Acute pancreatitis? Question mark. Why? Because if you recall, calcium is an activator for all enzymes. So calcium activates all enzymes, right? So this high calcium is going to cause activation of the pancreatic enzymes. When you activate the pancreatic enzymes, you are going to cause pancreatitis. Okay. And that's the pancreatitis. Other than that, you also have, okay, one more thing which they haven't mentioned here is going to be something PUD. You will also see PUD, which is peptic ulcer disease. Okay. And you also have nephrolithiasis. So you have renal stones, right? So nephrolithiasis and nephrocalcinosis. Okay, two things with these stones being there: nephrolithiasis and nephrocalcinosis. And what is nephrocalcinosis? Well, nephrocalcinosis is just the calcium being deposited in the kidney, nephrokidney. So calcium get deposited in the tissues, for example, in the kidneys. And what do we call when the calcium deposits in the normal tissue? We call it metastatic calcification, right? Which is in fact that you have high calcium that deposits in normal tissues. Here we will see nephrocalcinosis. Okay, metastatic calcification. And through this metastatic calcification, what's going to happen now is that you are going into renal failure because of this nephrocalcinosis. And that will also lead to polyuria and and renal failure. Okay. Other than that, some other thing that are worth mentioning are going to be, okay, let's talk about the bone pains. With the bones, bone pains are due to the fact that because you are inactivating the osteoclasts, right? And they are going to cause osteoporosis. Let me write it down. Osteoporosis, one thing. So unlike aging, osteoporosis are two types. Due to aging, you have osteoporosis. But here, because this is osteoporosis due to the fact that you have high PTH, right? And that will, unlike aging, with this, it affects the trabeculae. Unlike aging, which affects the trabeculae, this high PTH, again, let me repeat this. Aging in osteoporosis affects trabecular bone. Now, let's just make a bone here. And let's talk about the bone. So in the bone, you have a cortex and you have the trabecular part. So if you have the trabecular bone being affected, that is age related, aging. Okay, aging causing osteoporosis of the trabecular bone, but you have the cortex being affected. So that's due to that could be something else. But here we're talking about cortical bone being affected in infect due to increase in PTH. So increase in PTH will cause cortical thinning, leading to subperiosteal, I yield point, subperiosteal, periosteal, or periosteal erosions. Okay. Okay, that's one thing with the osteoporosis as a bone. But as you, there's something known as osteofibrosis cystica. Okay, I think I have them mentioned in here. Let me see. If it comes up, comes up. Otherwise, I'm just mentioning it here. The bone, we said osteoporosis. Second thing, we're calling it OF, osteofibrosis cystica. And this is an advanced, as the age, advanced age patient, advanced age. As the age advances, the patient can go into osteofibrosis cystica, okay? And that is pretty much what we have here. Now let's read, okay, actually they have mentioned here, osteofibrosis, fibrosica cystica, osteoitis fibrosa cystica. Osteoitis fibrosa cystica is the cystic bone spaces filled with, you have cystic bone spaces now, they're filled with brown fibrous tissue. Picture A. You can see this picture A. Okay. This brown tumor consisting of osteoclast and deposited hemosiderin from the hemorrhages. Okay. Again, you have a hemorrhage taken up by the macrophages, so hemosiderin-laden macrophages, right? And that causes bone pain. Why does this happen? Well, it happened because of increase in PTH, classically associated with primary or secondary seen with hyperparathyroidism. So either primary increase in PTH or secondary, no matter what, but you have increase in PTH, and that causes bone spaces, cystic bone spaces, which are not filled by the normal calcium, they're filled by the fibrous tissue. That fibrous tissue will be seen on imaging as black spots within the bone. And you can see it here. And it is seen, it is the disease of advanced age. Okay. Okay, that's pretty much what we have for the osteitis fibrosa cystica. Now the next part here, I think it's for the secondary. So let's just talk about secondary hyperparathyroidism. Again, we talked about primary being primary hyperthyroid. Now we're talking about secondary, that due to something we are going to go into hyperparathyroid hormone. Okay. Now, secondary hyperplasia. Well, why do we have secondary hyperplasia? Due to the fact that if you have a low calcium absorption or you have a high phosphate, that is going to cause hyperplasia of the PTA, of the parathyroid glands. Okay, most often when in the CKDs, most often in cystic kidney, not cystic, but chronic kidney disease, you have increase in phosphate, and that increase in phosphate and low calcium will stimulate the parathyroid. But since the parathyroid is there, but it will not be able to work on the kidneys, so it will be getting higher and higher. It will get stimulated by low calcium and high phosphate. So let's read the book here. It causes hypovitaminosis D, right? And why hypovitaminosis D? Because if you recall, vitamin D was getting activated in the kidney through 1-alpha hydroxylase enzyme. When we have CKD, the kidney is not working. When the kidney is not working, we might not have those cells there, or they might be atrophied or non-functional. So your 1-alpha hydroxylase activity is low. That's why you have hypovitaminosis D and hyperphosphatemia, because you were dumping out the phosphate through the kidneys. Now the kidneys are not working. When the kidneys are not working, you will have more phosphate, and that is going to cause, when you have phosphate, again, where does the phosphate loves to bind calcium, right? When you have a lot of phosphate, it's going to bind that calcium. You will not have free ionized calcium left in the serum, so you call it low calcium. And that low calcium is going to stimulate your, again, parathyroid hormones, parathyroid gland, leading to release of parathyroid hormone, and in turn you cannot work because you don't even have the kidneys, because you have a problem in the kidney, which is a chronic kidney disease. Hypocalcemia, we talked about it. Hyperphosphatemia, we talked about it in the CKD, versus hypophosphatemia with most other causes. Okay, this is very high yield that they're saying you have, which it makes sense. Kidney will dump out that phosphate, right? When you don't even have the functional kidney, you cannot dump out that phosphate. When you cannot dump out that phosphate, you're going to have hyperphosphatemia. But if you don't have a problem in the kidney, there is no way that there's a PTH and you're not dumping out the phosphate. As the name suggests, phosphate trashing hormone, and that's their job, right? They're not doing it if the kidneys have the problem, because that's where they dump. Think about your kidneys as the main place where you dump out the phosphate. Okay, something else. Let's look at this renal osteodystrophy. Here, what we have is renal disease causes secondary or tertiary hyperparathyroidism, which causes bone lesions. Again, if you have a renal disease, which is known as renal, but it causes bone lesions, so osteodystrophy. Why bone lesion? Because it's causing increase in PTH. Again, increase in PTH is going to stimulate osteoblast. Those osteoblasts are going to stimulate your osteoclast. Those osteoclasts are going to cause bone remodeling, take up all that calcium from the bone, put it back in the serum, and that bone destruction is going to cause bone lesions, and hence the name. And why did it all happen? Due to renal disease, hence the name renal osteodystrophy. That due to renal problem, renal disease, there is a bone lesion, okay? And in between you have increase in PTH as the main guy who is doing the actual work, okay? Now, with that, let's take a look at something CKD. So again, I want you to understand the CKD. When you have a chronic kidney disease, a couple things are happening. First of all, your GFR is going to go down, right? Not enough fluid to go there because you're in the chronic kidney disease. When there's a low GFR, guess what? GFR is the plasma that goes there, which contains the phosphate too. So you cannot even have the phosphate going down in the kidney. When you don't have the phosphate going down in the kidney, you have low phosphate excretion. That's one thing, right? Low phosphate excretion. When you have low phosphate excretion, essentially you're causing increase in phosphate in the serum, right? In serum, when you have increased phosphate, that's going to bind calcium, right? And when you bind more and more calcium, you are essentially causing low calcium, right? When you have low calcium, what is this low calcium going to do? Well, it's the only thing that you have for the calcium hemostasis is going to be you are going to stimulate your parathyroid hormone. You stimulate the parathyroid hormone, that's going to go and act on the bone and say, hey, I need calcium. Okay, so bone is going to eventually give calcium out and out and out, but eventually it's going to go into renal osteodystrophy, with leading to bone lesions. And why name it renal osteodystrophy? Because where's the main problem? Main problem is the renal. There's a renal disease which started the whole spiral, right? That is a perfect way to understand this. Okay, so let's look at the labs, and then we move on to the next thing. The labs, although not mentioned here, I mean, some are mentioned, so we're going to take a look from here. So you have a low calcium, increased phosphate, okay, increased PTH, increase in ALK phos, okay. So just remember one thing, which is very high yield, that you will have increase in phosphate level, okay, and low calcium, and increase in PTH levels. Okay, compare this secondary to tertiary now. Now, tertiary hyperparathyroidism, here you have refractory autonomous hyperparathyroidism resulting from end-stage renal disease. again, you have starting point, end stage renal disease. That end stage renal disease causes increased level of PTH, but now the PTH is stimulated so much all the time that now it became autonomous refractory. No matter now you give a transplant to the patient, still you're going to have increase in PTH. Why? Because they went into refractory autonomous hyperparathyroidism. Why? Because with end stage renal disease, you were stimulating the because you had low calcium, you were stimulating your PTH so much that now they are just autonomous. So that is why in labs you have high calcium, but very, very high PTH. Okay, you have high calcium, but very, very high PTH. And let's mention one more thing here. So what's going to happen to your phosphate with end-stage renal disease? Well, again, same thing, because you cannot throw out that phosphate in the kidneys. You're going to have increase in potassium. So now, wait, what's the difference between this and the secondary? The only difference is about calcium here. So here in the secondary, you had a low calcium, you had high PTH, you had high phosphate, but you had a low calcium. Here in the tertiary, again, you have high phosphate, high PTH, but again, high calcium. This is the difference with the primary tertiary. And the question is why? Because again, let's go back a step here. Why do we have all of this? Because here, all you had was that phosphate was binding to more calcium, leading to low phosphate. But here you say, hey, it's the same thing. You have more phosphate, which will bind to more calcium. But look at the phosphate levels. The phosphates are so much high that they will take up every single calcium from bone, causing increased calcium within the serum. Okay, that's the difference. That's going to be all for this. Now let's take a look at the last one here on this page. We have the familial hypocalciuric hypercalcemia. Okay, this is again very high yield. This is familial, so it's autosomal dominant. It is defective G-coupled calcium sensing receptors. So if you recall, you have a calcium sensing receptors, CASRs, calcium sensing receptors, right? These calcium sensing receptors, now here they're defective. So let's talk about normal first. And then we talk about abnormal, right? So let's just talk about normal. So normally what's really happening, you have serum calcium. If you have a low serum calcium, right? That low serum calcium, it is sensed by, think about these small nose, they're sensing, or some, these are receptors which are essentially sensing calcium levels, simple as that. So when you are low in calcium, these, what are these receptors? Let's mention that, CASRs, calcium channel sensing receptors. Again, calcium sensing receptors. They are receptors that regulate the secretion of PTH. So this is, let me just put up PTH. Let's say this is PTH. Okay. So if the calcium, so if normally what's happening is binding of the calcium is there, it binds to these receptors. When the calcium binds to these receptors, it leads to inhibition of PTH. But now when you have low calcium, no calcium is binding to these receptors, it leads to stimulation of PTH release. Okay, so when the PTH releases in the bloodstream, it causes calcium to go back up high, and that causes inhibition of PTH. Okay, this is all normal, but how are they working? That was the question, right? How are they working this calcium? How does this work? Well, this calcium, again, this calcium, when there's low calcium, which is sensed by these CASRs, let me write this down, CASRs. This CASR then causes, let's mention here, CASR, then it leads to activation of your GS cyclic protein, and that causes adenylate cyclase activation, which causes ATP conversion into cyclic AMP, okay? And that cyclic AMP will cause stimulation of the PTH to go out in the blood. And the question is now, how does the PTH work? And the PTH is in the blood. Now it acts the same way. Well, it works through GS coupled receptor, adenylate cyclase, activates adenylate cyclase, leading to ATP conversion into cyclic AMP. So look at the commonality here. Cyclic AMP, cyclic AMP. Oops. Yes, cyclic AMP, right? So now let's, with that in mind, let's look at the disease now. Disease is, we have defective G protein calcium sensing receptor. So we are talking about the defect of what? Of this here, calcium channel, calcium sensing receptor. GQ coupled specifically for the here for the calcium channel receptor. There's a problem in multiple tissues, for example, in the parathyroid and the kidneys. So it causes higher than normal calcium levels required to suppress PTH. So normally what is required is 8.4 to 10.0, 10.2. This is the normal level of serum calcium. It would, when you have normal calcium, it's going to get, it binds with CASRs and you are inhibiting PTH. But now you need higher levels of calcium so that you can inhibit the same thing, right? And that is one thing. Second thing is you have excessive renal calcium reabsorption, right? And leading to mild hypercalcemia and hypocalciuria with normal PTH, with normal to increase in PTH levels, okay? I think, let me make it a little more clear. You have defective GQ coupled calcium sensing receptors. You have a normal calcium which binds to the CSR. If you have your normal levels of this binding to it would inhibit PTH. But now in this hypocalciuric hypocalcemia, that you need increased levels of calcium to be bound to CASRs in order to inhibit PTH. So how do we get increased calcium levels? Well, when let's say only one molecule was inhibiting the PTH, now we need 3 molecules of calcium to inhibit the PTH. So now since we have normal, we're talking about normal here, we only have 1 molecule. This is not inhibiting PTH, so PTH comes out. When the PTH comes out, it causes renal to reabsorb all that calcium, right? So that's the hypocalciuric, meaning not calcium is not going into the urine. And one thing is there. And second thing is, again, it works through the bone, again, causes increase in serum calcium. Okay, with that, let's look at the text here. Higher than normal calcium levels required to suppress PTH, excessive renal calcium reabsorption, right? Which causes, when you're excessively reabsorbing more calcium, you're going into hypocalciuria, which is there, and also mild hypercalcemia with normal or increased PTH levels. Simple. Okay, I hope that makes sense. With that, I guess that's pretty much it. So now let's just quickly review this part and move on. Okay, here we have hyperparathyroidism, increase in PTH, right? Primary, meaning itself, there is an adenoma there or there's a hyperplasia. It's going to cause hypercalcemia, hypercalciuria, polyuria, hypophosphatemia, because PTH is a phosphate trashing hormone. So that's why it's going to cause hypophosphatemia. Increased PTH, increase in ALK-Phos. ALK-Phos because it causes stimulation of osteoblasts. Blast is the basics are the ALK-Phos environment. That's why ALK-Phos is high, because osteoblasts are activated. That increase cyclic AMP because you have a lot of PTH that is stimulating in the kidneys, reabsorption, causing increase in cyclic AMP because PTH works through what? GQ, GS, adenylate cyclase, cyclic AMP pathway. Okay. And most often it is asymptomatic, but may present with all of this due to the fact that you have increase in calcium, stone thrones, bones grown, psychiatric overtones. In bones, you will see osteoporosis. Osteoporosis, normally with aging, you have trabecular bone loss, but here you will have the cortical bone loss. Something is wrong with my pen here. Latency is not right, but what can we do? I'll try to fix it after this session, okay? What else? Abdominal pain, flank pain, pancreatitis because calcium, you have hypercalcemia. Calcium is activator for all enzymes. So when it activates a pancreatic enzyme, those pancreatic enzyme itself will activate more and more enzymes of the pancreas, leading to pancreatitis. Neuropsychiatric disturbances are there, psychiatric overtones, okay? It can cause osteitis fibrosa cystica, which is that it is activating osteoclast so much that is leading to formation of bone spaces, which are going to be filled by fibrous tissues seen black here on the imaging, okay? That fibrous tissue, okay? And then also you will have hemorrhages, so you will see hemosiderin-relating macrophages there, and which leads to bone pain. Increase, all due to the fact that you have increase in PTH associated with primary problem, which is adenoma, hyperplasia, or secondary due to CKD or end-stage renal disease, okay? And that's going to be pretty much what we have here. The next one here is all about, just remember the labs. And for the secondary, you will have low calcium, high ALP, increased PTH, and high phosphate. But with the tertiary, you have differences in the calcium. You have high calcium and very high PTH, and again, high phosphate. Renal osteodystrophy is a renal disease, for example, CKD, leading to activation of PTH, which essentially reabsorbs the bone, causing bone lesions. That's the renal osteodystrophy. Okay. The start point was CKD. Okay. Now, looking at the last one here, familial, as the name suggests, familial, so autosomal dominant. Where's the problem? You are going into hypocalciuria. Hypocalciuria means low calcium in urine because you are trying to absorb. That's the normal job of PTH, right? PTH causes, now normal job is to reabsorb all that calcium. It's going to do that. So it's going to cause all that calcium absorption to a level that it goes into calcium hypercalcemia. So it's reabsorbing every single point of calcium, okay? And that causes hypercalcemia, but mild only, and hypocalciuria with increased PTH. Okay, with that, we are done with hyperparathyroidism. Okay, let's take a break and we will be back with diabetes. I'm going to put up the timer. Okay, welcome back, guys. Let's start with most important topic. Actually, just 1 minute left, so just 1 second. Okay, welcome back. Let's get started. Okay, let's talk about diabetes mellitus. Okay, we have acute manifestations of diabetes mellitus, chronic complications, and then diagnosis. But the question is, why is it not showing up? Why is my pen not showing up? Give me 1 second, guys. I got technical issues here. Why is it not showing? Okay, here. Is it working now? Great. Okay, in acute manifestations, we are going to have three P's: polydipsia, polyuria. Polydipsia, increased thirst. Polyuria, increased urination. Polyphagia, increase in eating. Three P's. But these three P's are seen with type 2. Polyphagia being most commonly seen with type. Let's just mention it this way. Polyphagia is less commonly seen with type 1. Okay. Weight loss and DKA are going to be seen with type 1. Okay. Hope that makes sense. But if not, just remember that weight loss and DKA are going to be seen with most commonly with type 1. Young, thin patient, type 1 diabetes. Okay. Now, hyper or smaller hyperglycemic state is type 2. Okay. And we will talk about details of these two. The next is you have, they rarely can be caused by unstopped secretion of growth hormone. So if you have glucagon, growth hormone secretion, not glucagon, but growth hormone secretion unstopped, for example, if you have a problem with pituitary gland, it leads to formation of growth hormone, right? And that growth hormone over secretion or epinephrine over secretion, and or the patient who are on glucocorticoid therapies, steroid, all again, go back to again simple thing, counter regulatory hormone to the insulins are what? You have growth hormone, you have cortisol, you have epinephrine, right? All of these are counter regulatory to insulin, meaning these guys will keep will try to get all the glucose back into the bloodstream, causing diabetes, mellitus, while the insulin will try to put that glucose back into the cells. So that's the way they work, right? Simple. So here we have either we have a lot of growth hormone epinephrine, or we're giving from outside a glucocorticoid therapy, and that will all essentially cause diabetes mellitus. Okay. Now the complications, the chronic complications is very high yield, non-enzymatic glycosylation, glycation, non-enzymatic, simple thing as the name suggests, non-enzymatic. There is no enzyme involved. Glycation, addition of sugar, right? So without any enzyme, you're adding glucose, which is your sugar, onto the small, large, everything here. You're adding sugar or adding glucose to these things, right? But without any enzyme. That's called non-enzymatic glycation. So let's talk about where do we have non-enzymatic glycation, my bad. So you have a microvessel, micro means small vessel, and you have a macrovessel, meaning large vessel. So microvessel is a small vessel disease in which it's going to cause hyaline arteriolosclerosis, small vessel, right? Causing retinopathy, causing neuropathy, nephropathy. Okay, this nephropathy is essentially going to cause renal failure. Okay, with a large vessel, macro vessel, you are going to see, with diabetes, you're going to see atherosclerosis, which is going to cause coronary artery disease, cerebrovascular disease, for example, TIA, transient ischemic attack, or stroke. Okay, peripheral vascular disease. With the peripheral vascular disease, one thing that you will see is going to be the claudication. Okay, claudication. MI is the most common cause of death in patients with diabetes mellitus as a chronic complication. Okay, after this, okay, let me just go back. We had two sorts of chronic complication. One was non-enzymatic, and the second was osmotic damage. This osmotic damage is due to the fact that you have a sorbitol accumulation in organ with aldose reductase and decrease or absence sorbitol dehydrogenase. So let's go back a step, go back to biochem. We have glucose. Glucose gets converted to sorbitol by an enzyme, known as aldose reductase. Sorbitol gets converted to its metabolite by an enzyme, sorbitol dehydrogenase. So in the tissues where we don't have either the sorbitol dehydrogenase, or we have low amount of sorbitol dehydrogenase, or we have a lot of glucose outside that just gets converted into sorbitol, we are going to have a problem. Okay, so what are those issues? Those are, let's talk about them now. So that's the first thing, is neuropathy. Okay, neuropathy, you're going to have a motor problem, sensory problem. It is known as glove and stocking distribution. Okay, and autonomic degeneration. Example, GERD, gastroparesis, diabetic diarrhea. Okay, question is, why would we get this neuropathy? If you recall that in the PNS, peripheral nervous system, we get the myelination by Schwann cells, right? Those Schwann cells, they myelinate the peripheral nervous system. So they take glucose without insulin. So whatever glucose is there, they just take it, right? Now, what happens here is that when you have increased amount of glucose in the blood, that is taken up by these Schwann cells. So there's increased glucose in these Schwann cells, right? And that increased glucose will eventually get converted into sorbitol, right, by the aldose reductase enzyme, right? That sorbitol causes osmotic damage. Okay, it draws in the water, causes osmotic damage to the tissues where you have the Schwann cells, which is in the nerves. So it's causing neuropathy. Okay, neuropathy by the Schwann cells. Okay, now most importantly, in the sensory part, you will see decreased sensation on the foot, specifically decreased sensation of the foot. Okay, and when you have decreased sensation on the foot, it's going to cause ulcerations there, right? You had a minor trauma, you eventually bumped into the door on a chair somewhere, right? It causes small ulceration. That ulceration you don't even notice it because you don't even have a pain there. So that ulceration can go into infection, and that can lead to osteomyelitis. Okay, that's with the decreased sensation of the foot. That is why And that is why, let's just write it here. That is why all patients with diabetes mellitus should get checked for, should get the feet checked every visit. On every visit they have to the primary physician, they should get the physician should check the feet. The foot should be checked. The feet should be checked. Okay. Not only that, but also they need diabetes patients. They need all diabetic patients, and they need pneumococcal vaccines. Pneumococcal vaccine. They let's just write it somewhere. So pneumococcal vaccine. Okay, one thing. Second thing, these patients with diabetes, they need to be on ACE inhibitors or ARBs. ACE or ARBs. Why? Because for the blood pressure, right? For the if the BP is greater than 140/90, which is high blood pressure, simple as that. Either high blood pressure or they have microalbuminuria, which we will talk about in a bit. Microalbuminuria. Okay, put the patient on ACE inhibitors or ARBs. Third thing, they should be on statins. If the LDL is greater than 100, so if a diabetic patient has LDL greater than 100, put them on statin. Fourth thing, you have to use aspirin in these patients. Okay, why aspirin? Because they are at high risk of formation of cardiovascular disease, cerebrovascular disease, and peripheral vascular disease. You want to put that on aspirin. Okay. Fifth thing, not only foot you want to check, but also you want to go for eye checkup. So let's just put eye plus foot exam yearly at least. Exam yearly must be done. Okay, yearly for the eye. Why? Because we want to look for retinopathy, which is proliferative retinopathy. Proliferative retinopathy. High yield diabetic patient goes into a proliferative retinopathy. For the foot, they are just going to neuropathy and formation of ulcers. Neuropathy with ulcers plus ulcers. So these are all the complications and how they should be, how to treat these diabetic patients. Not only you just want to put on metformin or any other drug, but also you got to take care of all its complications, which will eventually rise due to diabetes. Okay. So with that, what else we might can think of? Okay, with that, let's also think about cataracts, lens, right? In the lens, the same way. What happens in a cataract is that lens will take up that a lot of glucose that was in the bloodstream. It's going to take that glucose up. That glucose is going to convert into sorbitol. That sorbitol is going to cause osmotic diuresis, lead to formation of cataract. L-daughter restrictase is an important enzyme, right? Okay, with that, now the question arises, how do we get this retinopathy in these patients? Again, retinopathy is going to be associated with, so we have pericytes. We have pericytes on the blood vessels, or pericytes of retina. In the retina, we have the pericytes. Pericytes is everywhere, but here specifically we're talking about pericytes of the retinal blood vessels. What they are going to do, they are again going to get damaged by these parasites. Are going to take up that glucose. That's going to convert to sorbitol. Sorbitol is osmotic diuretic, not diuretic, but osmotic. It's going to cause osmotic damage to these parasites. When these guys get damaged, it's going to cause hemorrhage, right? Hemorrhage in the retina, and hemorrhage in the retina is the proliferative retinopathy, leading to eventually causing blindness in these patients. Retinopathy causing blindness with the diabetes. Okay, so that is with that. Let's talk about gastroparesis. Now, gastroparesis is diabetes. What's really happening with the clinical features that you have a patient who's diabetic for years, and it's going to be even if when the patient eats, after the eating you have postprandial fullness. After a small amount of eating, the patient will have prandial, meaning after they eat, postprandial. Fullness is there, fullness. This is specific for gastroparesis, in which basically the guts are not moving, food is staying there, causing fullness. And that fullness will give you not only fullness, but you will vomit that out, and you will also feel that bloating, okay, with just small amount of food. Okay, gastroparesis, because nothing is moving forward, again, due to neuropathy, due to damage to the nerves there. Okay, and now how do you treat this? Now, very high yield is the treatment. Now, for the treatment, you can give two things. The first thing you can give for the gastroparesis is your metoclopramide. Let me write it down. Metoclopramide, which is your D2 receptor agonist. But the problem with this drug is when you give this drug to this patient, the patient will develop extrapyramidal sign and symptoms. Extrapyramidal sign and symptoms. So you could do another thing, which is called macrolide, which is an antibiotic. For example, erythromycin. You can give erythromycin, which will stimulate. Now, important thing is, what are they going to do? They will stimulate motilin receptor. When the motilin receptors are stimulated, it causes motility of the gut, leading to movement of the gut, causing food to pass, leading to you would not feel any fullness or any bloatiness or vomiting or anything with the gastroparesis. Okay, what else we can think of? With the autonomic, one last thing is about this autonomic degeneration. We talked about GERD, gastroparesis, diabetic diarrhea, but we have one more thing: hypotension. It is an autonomic degeneration, all due to the fact that you have neuropathy, peripheral nervous system is out. You have autonomic degeneration, causes hypotension. Okay, hypotension in these patients. Okay, with this, let's look at the diagnosis. How do you diagnose diabetes? Well, to diagnose it, you have the test. The first test we have is A1C levels, HbA1c. Diagnostic cutoff is greater than or equal to 6.5%. Okay. It reflects average blood glucose over the 3 months. So average blood glucose. So the more, let's say your average was, let's say 200. So about more and more RBCs will, the glucose will bind to more and more RBCs, and that's exactly what we see in A1C. How much of glucose is bound to the RBCs? Glycosylated hemoglobin, right? How much of the hemoglobin has been glycosylated? Simple as that. Over the month of 3 period. Why? Because RBC has a life of 120 days, which is essentially 3 months. After that, they die, and the new RBC come up. When the new RBC come up, then they again have to bind to the glucose in order for us to see. So 3 months. So this test is good for 3 months. After 3 months, do another HbA1c to see the diagnostic cutoff, which is 6.5. Now with that, there's again, when we think about a problem here, which is a 3 months, we also have to think about what if a patient has a rapid erythrocyte turnover, so rapid RBC turnover. What's going to happen to that patient? Well, first of all, who is that patient, or what disease you see rapid erythrocyte turnover? Let me tell you an example. What about, do you think about beta thalassemia? Do you think about sickle cell anemia? You are right then. Beta thalassemia patient, sickle cell anemic patient, they have a rapid RBC turnover. When you have a rapid RBC turnover, guess what? This is not going to work, because now you see level is normal, I think 5.4. So you have a normal A1C level, right? But it's not the case, and the patient is going to diabetes, and you're thinking, hey, normal level, no way diabetes. But no, yes way diabetes, because there is an RBC turnover. The RBCs, instead of these 120 days, now they're turning over every single day. You don't even have the actual data there, so you cannot use HbA1c in patients who have rapid turnover. So what can we use as a substitute to this? Well, we can use something known as fructosamine. So let me write this down. Fructosamine. This fructosamine. So in patients with a rapid erythrocyte turnover, for example, they have hemolysis, hemolytic anemias, or sickle cell, beta cell, and all of that. In these patients, the glycated serum protein fructosamine is used to see the levels. And it's not always used; it's only sometimes used. So that's only one thing that we can think of. But remember, most important is not fructosamine, but what is important is in your hemolytic diseases, you cannot trust your HbA1c. Simple as that. Now, moving on to fasting blood glucose levels. So fasting plasma glucose levels is diagnostic cutoff is 126. Okay, greater than or equal to 126. Anything from 100 to 125 is going to be your pre-diabetes. Above or equal to 126 is going to be your proper diabetes. Okay, pre-diabetes is pancreas are like, hey man, we can't match up whatever you're eating. We're trying to produce as much as we can insulin, but hey, it's not working. So pre-diabetic patients eventually will go into diabetes unless or until they fix their diet, exercise, and do something about their life, right? That's one thing. So what are the notes here? Fasting for greater than 8 hours. Again, what you mean by fasting? How long you have to fast to check the blood levels? Well, 8 hours or greater than 8 hours. Simple as that. Now the next point is 2 hours OGTT, oral glucose tolerance test, has to be greater than or equal to 200. 2 hours after consumption of 75 grams of glucose in water. Okay, so you give the patient 75 grams of glucose. After 2 hours, you check the blood sugar levels. If they are greater than 200, if they're greater than 200, you say, okay, you are diabetic. That's as simple as that. Now, the random plasma glucose levels, you have greater than 200. Randomly, you check the plasma glucose levels greater than 200. So presence of hyperglycemic symptoms is required. Okay, with this, greater than 200, but you got to have symptoms of hyperglycemia. Okay, and that is going to be all for this. But one more last thing is should be here that this plasma glucose should be done at least at 2 different occasions, and then you can say, okay, we have a problem, right? And that is it for diagnosis. Let's look at this table chart, whatever you can call it. Pretty nice one. Okay, when you have decreased available insulin, basically insulin deficiency, in other words, insulin deficiency, what's going to happen? Well, we're going to have increase in lipolysis, increase in proteolysis, increase in gluconeogenesis, formation of glucose, breakdown of glycogen, decreased tissue glucose uptake. So if you go back to normal physiology, we have insulin, what normally insulin does. Here, everything is opposite. So in other way, you can think about glucagon. Glucagon does all of these things. This is normal physiology of glucagon, okay? Glucagon causes increase in lipolysis, increase in proteolysis, increase in glucogenesis, and increase in glycogenolysis. And also decrease in glucose uptake. More specifically, decrease in glucose uptake, glycogenolysis, and gluconeogenesis. And these are just extras, lipolysis and proteolysis. So when you have insulin deficiency, you're doing a there's a breakdown of fats, right? Lipolysis, breakdown of muscles, proteolysis, right? So let's talk about now the whole thing. So when you lose your fat, not lose fat, but when you are trying to break down the fat, you are going to cause increase in free fatty acid in the plasma. Simple as that, right? That is going to cause increase in ketogenesis. Where does the fat has to go into some metabolism, right? So for the fat, the metabolism is ketogenesis, formation of ketone bodies. Simple as that. Okay. So it's not only going to go ketone bodies, but it's that ketonemia, meaning it's going to be in the serum. Ketonuria, that ketone also go into urine as well. I mean, simple as that. But the problem here is it can go into anion gap metabolic acidosis. Okay. That's important. Other than that, you have with this, when you are going into metabolic acidosis, you are going to, because it's a metabolic acidosis, you will try to lose that acid by ventilation. That acid is going to be your carbon dioxide. You want to try, you would lose that by giving hyperventilation, increase in respiratory rate, increase in hyperventilation. You're throwing out that carbon dioxide, essentially decreasing your pH levels. Okay, and you have Kussmaul breathing. Hyperventilation is known as Kussmaul breathing. Simple as that. Okay. With ketogenesis, ketonuria, ketonemia also leads to vomiting. That vomiting causes loss of water, sodium, and potassium. Right. Let's stay here and let's look at the rest of this verse. Proteolysis, breakdown of proteins, causing decreased muscle mass. That decreased muscle mass and also causes weight loss. Again, the fat, if you put 5 pounds of fat and 5 pounds of muscle, you won't see the difference. Only, let's say, this much of muscle is 5 pounds and this much of fat would be 5 pounds. Okay, so when you're losing the muscle, you're losing the weight, you are happy, but the problem is you're losing muscle, which you could make if you are not that old. So no problem. As long as you're going for weight loss, I say it's a green signal. But in turn in life, you got to go for weightlifting, make that muscle up. But again, weight loss, proteolysis. With that proteolysis, all that protein is going to go into formation of more glucose, gluconeogenesis, more glucose formation. Glycogenolysis, glycogen gets destroyed, not destroyed, but breakdown of glycogen, which essentially is glucose, causes hyperglycemia and glucosuria. That glucose in the blood goes into urine, causes glucosuria, and that would lead to osmotic diuresis. That glucose in the urine draws more water in the urine. That is going to cause osmotic diuresis. Basically, you're losing more water. When you're losing more water, again, you're losing water, sodium, potassium, going into hypovolemia. That hypovolemia can lead to circulatory failure and decrease in tissue perfusion. Okay, although these are just theoretical. Okay, theoretically speaking here, this is the normal functions. Okay. Here on the other side, that again, hyperglycemia and and glucosuria, glucose in urine causes increase. That hyperglycemia would cause increase in plasma osmolality, and that is going to give you increased thirst. So didn't we just look at, okay, we called polyuria, polydipsia, increased thirst, polydipsia, increased urine, polyuria, right? Lastly, we have decreased glucose uptake. Now, if all of these are causing increase in glucose in the blood, but if you only had one thing to put that glucose back into the tissues, you wouldn't have any problem, right? So the problem is where? This is the main problem, that you cannot uptake that glucose because you don't have insulin. So that glucose stays in the blood, causes more and more damage. And it's just a silent damage. You don't even know about it. All you're doing is polyuria, polydipsia. Polyuria, going in, urinating more than normal and drinking more than normal. And you think, hey, that tablet, 500 milligram of metformin, is doing the work. Well, it's not. Maybe increase the dosage. Who knows? But that's what we have for this one, okay? With that, let's talk about the last point here, which is not mentioned here. That's going to be your counter-regulatory hormone. So Uh, the counter-regulatory hormone, if you have low insulin, which we just talked about here in the whole thing, if you have, this is just a summary of what I'm mentioning. If you have low insulin, simple thing, you have decreased peripheral glucose utilization, peripheral glucose utilization, one thing. Second thing is going to be you have increase in hepatic gluconeogenesis, meaning formation. Neo means formation of glucose. Glycogenolysis, breakdown of that glycogen, right? And this is decreased insulin. If you have increase in glucagon, that is again going to cause increase in gluconeogenesis and increase in glycogenolysis. Same thing here, but differently. It's just going to cause the same things. But epinephrine, so forget the different part here. Epinephrine, what is going on? Okay, excuse me. Epinephrine, increased epinephrine, is going to cause the same thing, which is increase in hepatic gluconeogenesis, glycogenolysis, glycogen breakdown, formation of glucose, and also is going to cause increase in mobilization of glycogenic substrates. That is even not important. Forget that part. The last one is cortisol and growth hormone, which you talk about. Cortisol and growth hormone, they are going to alter the transcription factors, right, of many genes to conserve glucose. Okay. And these are these are going to be your counter-regulatory hormones. Insulin is the only one which is not part of the counter-regulatory hormones. Everything else, glucagon, epinephrine, cortisol, growth hormone, are all counter-regulatory hormones. Okay, and that's pretty much all we have for this one. So let's just review it quickly and move on to next. Okay, diabetes, acute manifestations, polyuria, polydipsia, polyphagia. 3 Ps, weight loss, DKA, seen with type 1, most common. Thin, lean patient, you see it, you call it type 1. Okay, HHS will be seen with type 2. With that, but again, diabetes, meaning a lot of glucose in the blood, can be also caused by growth hormone, high level of growth hormone, high level of epinephrine, high level of cortisol, glucocorticoids. Chronic complications are going to be your non-enzymatic or osmotic. Non-enzymatic is a microvascular, which is small vessel, and macrovascular, which is large vessel. Micro, small vessel will go into hyaline arteriolosis, small vessel, retinopathy, neuropathy, nephropathy. Large vessel, atherosclerosis, big guys, coronary artery disease, cerebrovascular disease, peripheral vascular disease, which lead to claudication. MI, most common cause of death. Osmotic damage. Osmotic is due to sorbitol. We mentioned this one. Sorbitol converts, what am I saying? Glucose converts into sorbitol by aldose reductase. And this sorbitol it causes the osmotic damage. Where is the damage? It's in the neuropathy, in the peripheral nervous system, PNS. In the peripheral nervous system, which cells are going to be affected? Schwann cells. Schwann cells are going to take up all that glucose, which is going to convert into sorbitol, and that sorbitol, which causes damage, osmotic damage within the Schwann cells. You knock out your Schwann cells, you knock out your peripheral nervous system, you're causing neuropathy. With neuropathy, you have a motor neuropathy sensory. You can't even feel your foot. When you can't feel it, you're going to cause ulcer. You cause ulcer, it's going to cause infection. It's going to cause osteomyelitis. Autoimmune degeneration is going to cause hypotension, GERD, gastroparesis. Your gut is not even moving with the diabetes. So when the gut is not moving, diabetes, you treat with metoclopramide or erythromycin as a macrolide, which stimulates which receptors? High yield motilin receptors. Okay, with that, you have cataracts. Lens, again, take up that glucose, convert them to sorbitol. Sorbitol goes and causes osmotic damage, causes cataract formation. Retinopathy, again, retinopathy being parasites of the retinal blood vessels, getting all that glucose, getting all that glucose conversion into sorbitol, damaging these parasites. When you damage the parasite, it leads to hemorrhage, and that hemorrhage is going to cause proliferative retinopathy. You will see dot blood hemorrhages, flame, and all that, and you can see that back in your um, ophthalmology section. Lastly, diagnose A1C. That's levels are going to be more than 6.5, but in hemolytic diseases, A1C will not work because you're getting new bloods, new RBCs, and that's not going to be an effective marker. Excuse me. Okay, so for that you can use, for hemolytic diseases, you can use fructosamine. Fructosamine. Okay, then fasting blood glucose level at least on 2 occasions greater than 126, 2 hours OGTT greater than 200, random greater than 200. Okay, with this, all you have is, if you think about it, just whenever you have low insulin, everything is high. Lipolysis, proteolysis, gluconeogenesis, glycogenolysis, everything is almost high, right? One thing is low, which is, if you know a little bit, you will know that, okay, there's a decreased glucose uptake for sure. No rocket science about it, right? And when you increase lipolysis, you're increasing ketogenesis, simple as that. When you're increasing proteolysis, you're decreasing muscle mass, but you're forming glucose. Glycogenolysis, you're causing hyperglycemia. Hyperglycemia is going two ways. It's going in urine, is going in serum. In serum, you're causing increased plasma osmolality. That's going to cause increased thirst, polydipsia, right? With the glucose in the urine is going to cause hypovolemia, and in the urine, because you're urinating a lot, it's called polyuria. Simple as that. And that's all for diabetes. Okay, let's take a break and then we will come and finish this up. Type 1 and type 2 diabetes. Okay, welcome back. Let's start with this. Very high yield. So now let's talk about type 1 and type 2 diabetes mellitus. Okay, so here what we have is type 1. What is the primary defect in type 1? It is an autoimmune, again, very high yield, is autoimmune T cell mediated, T cell mediated damage or destruction of the beta cells, which are the islet cell cytoplasm plus or minus anti-glutamic acid decarboxylase plus minus insulin autoantibodies often present. So these are high yield T cell mediated autoimmune destruction of the pancreatic beta cells, and this is going to be a progressive destruction of the beta cells, which will essentially cause absolute insulin deficiency. Okay. And the question arises now, why would you have this autoimmune destruction? Like, who is going to stimulate this autoimmune destruction of the pancreas, right? So it is triggered by, what is a trigger essentially? It is triggered by environmental factors or environmental stimuli in genetically susceptible individuals. So someone who is genetically susceptible, they get triggered by some environmental stimuli that triggers the autoimmune destruction of the pancreatic beta cells. Okay, so this is whole pathophysiology behind the destruction of the pancreatic beta cells. And it's a progressive disease, meaning it does not happen right away. It occurs after some time. So with time, there's a progression of type 1 diabetes. For the type 2 diabetes, all you have is increase in resistance to the insulin, right? And that causes progressive pancreatic beta failure. Because now you have resistance, no matter how much insulin gets produced by the pancreatic beta cells, there is going to be failure of that pancreatic beta cell, because the way they're producing so much of insulin, and still that is not working, so they will go into failure. But it's going to cause relative deficiency. So relative deficiency of insulin. Here you have absolute deficiency of insulin. Okay. So this progressive beta cell failure is basically exhaustion. These beta cells of the pancreas gets exhausted. Okay. And then they would just fail and not make any insulin because they went into exhaustion. Okay. That's the first thing you will see in type 2 is first you will see resistance, followed by a lot of insulin being formed, but that insulin is not working because there is resistance. So beta cells are going to go in overdrive, making insulin, not working, then leading to getting into exhaustion, which is going to be insulin secretion deficiency. But again, it's a relative deficiency, not a absolute complete deficiency. Okay. Then let's talk about the second line, that is going to be insulin necessary in treatment. Because you have it here, you have an absolute insulin deficiency. For sure, you need insulin from outside, but here you don't have insulin deficiency. The problem is the resistance. So you might need it sometimes when the beta cell go into exhaustion or failure. At that time, you would need an insulin from outside, but that's again with the advanced diabetes mellitus type 2. Age is less than 3. Again, young, thin patient, greater than 40 is for the type 2 diabetes. Associated with obesity? No, it is not associated with, because it is associated with environmental stimuli in the genetically predisposed or genetically susceptible individuals. And for this, the other one is, yes, the obesity is the main culprit. Let me just talk about the obesity action in type 2 diabetes. So factors that contribute to insulin, let's just write it here, factors that contribute to insulin resistance. What are they? First and for most important, you will have obesity. Insulin resistance is happens when you're obese. So obesity causes that, and when you're obese, you are having a sedentary half-life. Not half-life, but a lifestyle. My bad. When you're not active, right, in your lifestyle, you're essentially obese. When you're obese, because if you're active in your lifestyle, you won't get obese. When you won't get obese, you're not going to form insulin resistance. Obesity, sedentary lifestyle, that's one factor. The second thing is with insulin resistance, you can see something known as acanthosis nigricans. Acanthosis nigricans or nigrans. This is essentially signs of insulin resistance. You can see in the neck folds, meaning on the backside of the neck, in the axilla. You will see hyperpigmentations or velvety appearance of the skin. That is known as acanthosis nigrans. This tells us there's insulin resistance, but it's also associated with colonic malignancy. But with an obese patient, you are thinking more of insulin resistance. Okay. What else we can have? So yeah, this is it for the obesity. Now, next line is genetic predisposition. Although you think about, when you think about diabetes type 1, you think about, hey, it's the genetic type 1, but it's not the case. It's not the case. Amigos, it's a little different, because if you look here, genetic predisposition is weak for type 1. 50% concordance in identical twins. Polygenic. Polygenic is the word here. Why polygenic? Because it's due to environmental. Everything is affected here. So environmental factors plus your genetically susceptibility in genetics is there. But again, you need environmental factors as well that would initiate the problem. Well, for the genetic predisposition for type 2 is strong. 90% of the concordance in identical twins and polygenic. Okay, but which is genetic predisposition in type 2 is strong. Okay, then you have HLA system. HLA, you have HLA-DR4, DR3, 4-1, 4-3 is type 1. So they are saying type 1. I guess this is important. That's why they mentioned this mnemonic type of thing, 4-3 type 1. So just remember DR3, DR4. That's give you type 1 diabetes. And HLA is not associated with type 2. Regulation or no, glucose intolerance. Glucose intolerance is severe. It is severe in the 1 and mild to moderate into insulin sensitivity is high, because here is the insulin deficiency. Here you have insulin deficiency. That's why sensitivity is high, because the body is not having insulin. But for the type 2, we have insulin. Its sensitivity is low because there is a resistance to the insulin. That's why sensitivity is low. Keto acids are commonly formed in the type 1 and rarely found in type 2. Okay, beta cells number in the islets is decreased because they have been destroyed, right? But here's a variable, but what you will see high yield is amyloid depositions. Amyloid depositions, or if you see anywhere amyloid deposition with the pancreatic beta cells, you're going to think about type 2 diabetes. So why is the amyloid or how the amyloid gets deposited here? Islets amyloid polypeptide is beta islet amyloid polypeptide is known as amylin. Amylin gets secreted by with insulin. So it is secreted along with insulin. And more insulin gets secreted, more amylin gets secreted. When the more and more amylin gets secreted, it gets deposited. It gets deposited, and leading to formation of amyloid. Okay, and it get deposited in the type 2 diabetes, where you have a lot and a lot of insulin being secreted out, and that is going to cause a lot and a lot of amylin being secreted out, and that is just going to cause deposition, leading to amyloid formation or amyloid deposition within the pancreatic beta cells seen in type 2. Then you have this insulin level. For sure, they're low, and for sure high initially, which I mentioned, but with age, they're just going to decrease because of exhaustion of those pancreatic beta cells, or deficiency, not sort of a deficiency, but a failure of the pancreatic beta cell. They will get exhausted. They're like, hey, man, we're trying to put that insulin out, but it's still not working. No matter how much we produce, not working. They're going to go in overdrive and eventually go into failure. And that's exactly what we have later on the disease. There's going to be low insulin. With the classic symptoms are going to be common. What are the classic symptoms? Polydipsia, polyuria, polyphagia, weight loss. All of them are common with your type 1. Okay, weight loss for sure. 100% you see that with type 1. Everything else you also see that. But with the type 2, you don't see many of these symptoms. More likely you see polyuria, polydipsia, nothing else, not all these. But sometimes they are present. Polyuria, polydipsia sometimes can be present. Histology is again high yield. You have islet leukocytic infiltration. Leukocyte get infiltration. So there's first of all, there's an inflammation of the islets. The inflammation, let's talk about it. So in type 1, you will see inflammation of islets. Inflammation of islets, not only inflammation in T cell, but also you will see autoantibodies, which we talked about up top here. All these antibodies, they are going to be against your islet antigens and insulin, eventually causing these two things: inflammation by the T cells, destruction by the T cells, causing inflammation, and autoantibodies causing destruction. All of them will cause essentially destruction of the pancreatic beta cells, leading to type 1 diabetes. Okay, that is the leukocytic infiltration is high yield. Again, T lymphocyte being infiltrated into the pancreatic beta cell. That's important. Other than that, you also have, on the other hand, histology, you have islet amyloid polypeptide. Which amyloid polypeptide? Amylin. Amylin gets deposited. Okay. As you know, the myelin gets secreted with insulin. When the insulin gets secreted, myelin also gets secreted. Okay. And it just gets deposited within the pancreas, leading to formation of amyloid. Okay. Then we have, what would be the treatment options for type 1? Well, because we have absolute insulin deficiency in type 1, we want to give insulin. Simple as that, right? So we want to give lifelong insulin to these patients. For the type 2, because they are often clinically, they're silent, right? They don't know, the patient don't know, right? So they have, they first of all, if you do diagnose them, then you have, first of all, you would want to go with weight loss. Obesity is the main culprit here, right? Weight loss. Then you want to go for, if weight loss is not working, then you want to go for drugs to counter that insulin resistance, like for example metformin and all that. Or then essentially at the later stages you want to give insulin. Okay, but we will talk about drugs in the details later on in the pharmacology section. Okay, now let's talk about a couple more important points and then we move on to next. So the couple important points are that you have. So let's talk about some polygenic or what is it associated with. So it can occur in susceptible individuals who are exposed to, as I mentioned, exposed to environmental factors, right? What are some environmental factors? For example, viral infection will cause that. Somebody goes into viral infection, they cause autoimmune disease, and that leads to that's the way it can go. Or some environmental toxins can initiate the process. Or lastly, you can have some dietary component. Somebody ate something, dietary component. Any of this can start the inflammatory process, okay, and initiate the problem. And for the other one is going to be that you have insulin resistance as the problem. Insulin resistance as the main problem, right? Why would you have insulin resistance? The most important factor for insulin resistance is obesity. Why is that? Why would obesity cause insulin resistance? Because obesity decreases the number of insulin receptors, okay? When you decrease the insulin receptors, so no matter how much insulin you have, because you don't even have the receptors, it's not going to work. So that's the way obesity causes insulin resistance. That's one thing. Second thing, you have to remember abdominal fat deposition. Abdominal fat deposition also causes insulin resistance. Okay, excessive body weight, so ABD, abdominal fat, excessive body weight, obesity. All of these cause insulin resistance. Now, when we talk about this abdominal fat deposition, you have to know one thing now. Intra-abdominal visceral fat is more important than subcutaneous fat. So intra-abdominal visceral fat, I mean organ, on top of the organ you have gut fat. That fat is more important causing diabetes and all the other things like atherosclerosis, increase in you have all the metabolic syndrome and everything. So you have intra-abdominal visceral fat is more important than your subcutaneous fat. That's an important thing. Okay. And with that, I think I did cover majority of things. Destruction. Let me see. Okay, yeah, one last thing for the type 1. For type 1, we have beta cell function, and we have progression of type 1 diabetes mellitus. So the first thing we have, first of all, here we don't have any beta cell dysfunction, and this is what you have is a genetically susceptible individual. Your beta cell function is at 100%. But with the environmental stimuli or environmental factor triggering the autoimmune response, your beta cell function goes down to about 50%. Okay. And with that, you have, for example, autoantibodies being present, autoantibodies causing more and more destruction. And you're going to hit about 30% with that. So here's the 30% of that. And then lastly, so if you look at it, your beta cell function is progressively going down and going to zero at a point. There will be a point that you will be absolutely, beta cell function will be zero. There is the absolute insulin deficiency. And the signs and symptoms of diabetes, and that's also about signs and symptoms of diabetes mellitus, they would occur when you have greater than 90% of your beta cells being destroyed. So again, this is important. 90% of the beta cell getting destroyed. At that time, you will see, you will get the diabetes sign symptoms. And that is all for diabetes. With this, I guess just let's conclude this for today, and we will move on with the DKA because they're little important topics. So I want you guys to have very good focus. DKA and HHS, which is hyperosmolar or hypercalcemic state. We'll continue that with tomorrow. Okay. Thank you so much all for joining, and good luck.